So that's why you keep your basic correct, that will be fine. But definitely you need to prepare very good your long and short cases. So there are certain things which can be asked in long cases that you prepare. There are certain things which can be asked in short cases that you prepare. That service. So you have to divide that. But probably after, because the first time exam is being going to conducted, this will also depend upon who is the chief examiner. If I mean, nobody should feel offended, but anybody from public sector or private sector is no, I mean, I'm not going to offend, but definitely if your exam center in a public sector hospital, you will have a difficulty in facing the question, because most of the time you people are trained in a corporate hospital where functioning and working approach is different than what it is. So to fill up that gap, just only way you can do it, just keep your basics correct. Because many a time, because it's an unfortunate part, but many a time the questions being asked is not standardized rather than what examiner feels he asked. While the exams which is conducted by society or previous FNB exam, because most of the people from the IS system were the examiners. I do not know what is going to happen in current scenario in DNB. So still the questions were very far standard and evidence based, and what is to be done. We do not know how, but in general, it's very, I mean, time will take some time to get the thing standardized. We do not know how it's going to shape up. And that's why to defend ourselves, we should be ready with all the, if you correct your basics, you will be okay. If you do mistakes in basic, that's going to be a problem.
Okay.
Yeah.
Sunil, anything you want to add or ask Rajesh? Yeah.
Yeah, no. Nothing to ask Rajesh. Right. So Rajesh is has been a good colleague of mine. Has been we studied together, worked together briefly, and all that. So I think just to clarify on what Dr. Rajesh said, I think when he said public hospitals, he is more referring to a teaching hospital, I suppose, isn't it, Dr. Rajesh?
Yeah.
So definitely, rightly, I fully agree and endorse whatever Dr. Rajesh has said. So there is going to be a fundamental difference for an examiner who comes from a corporate sort of a setup and who come from a teaching kind of a setup. So probably a little more emphasis on basic sciences, a bit of theory and those kind of things, while probably in the corporate or more sort of private hospital will be more management-based approaches. So unfortunately or fortunately, I happen to be the first batch of FNB. So I understand what are the blues that this batch will be going through. In fact, when I did my FNB final, I didn't even know whether there's going to be an exam. In one fine day, we got a hall ticket saying that you come to Delhi 10 days later, Pune. But it was kind of not the days of internet, and you know how difficult it is to contact the national board. So that apart, I would grossly say get your preparation in two aspects. One is there could be centers which may say, let me have 4 or 6 short cases, which is a problem solve or a specific problem based approach. It could be like what are the causes for this patient not weaning, or what are the causes for encephalopathy, what is the cause for AKI. So that kind of a specific thing, which would mean focused examination of all systems and all relevant systems. Or it could be a broader long case like how we have in our MDs, where they would say, this is a patient, so such and such age, have a look at him and give us the issues or problems, or how do you want to manage this patient henceforth, etc. Or we could have a combination. There could be centers which will say 2 long cases, 2 short cases, or something like that. So I think there would be certain uncertainties, but it's not something that we can't get over. I would actually say get prepared for both aspects. And when we talk about a long case, probably the history presentation will be a little detailed, not like how we did in MBBS, fever 10 days, cough 4 days. Not in that sense. It will be more summarized, like febrile illness with cough presented with so many days duration. That way, that is how it would be probably for a long case, or even for that matter, Sham. So get your preparation in both sides ready, because if somebody asks you that we want a more detailed presentation, you should have that available and ready as well. What I would suggest is, in terms of practice, the best people to examine you would be your own colleagues who are giving exam with you. Because we would both of you are in the heights of your theory preparation. You are extremely knowledge ridden at this point of time, and you will be very eager to go at each other's neck. So I think the best way would be to get your fellow examiner either from the same hospital, I would even say from a nearby adjoining hospital. So good thing would be to have a weekly meeting of 2-3 hospitals in a given hospital. Say if today you are doing it in hospital A, tomorrow all of you go to hospital B and hospital C, that way. So in a week you would have seen in different hospitals and get your own colleagues to do examine. If you get a consultant, well and good, but I think more cases you do, the better you will get at it. So passing exam, I think the theory bit is done. So from now it is the knack and the art of how you present. Because many a time, as Dr. Rajesh said, you are good in your work, you have done everything, but if you are not able to put that knowledge across, that will probably become your bane in your exam. And rightly, as Dr. Rajesh said, be very calm, because often when you go, you see some big face or a big examiner walk in, then the immediate reaction is, oh, okay, I'm gone. So don't be like that. I think the effort of the examiner is largely to pass you. I don't think anybody would be keen. In fact, if we have a result which is below a certain percentage, we have to actually give an explanation to any board. It could be the board, it could be the society. We have to even mention why we have failed a given candidate or a set of candidates. The other important thing about the national board, probably akin or unlike the IDCCMEs or any exam for that matter, I think is to see train somebody to become a consultant. So you have to have that mindset that henceforth I'm going to become a consultant, and that is what we are training you for. A good, safe, and a logical prospective consultant is what we are going to train you for. So it's very important to understand that, because if you think like a consultant, you will think more maturely. And that is when you start thinking about prognosis, communication. Your communication things get better. I think that is something you need to be calibrating yourself. So the next 2 months or 1 month or whatever duration we are going to have is cases, and all, and just keep practicing cases. And very honestly, we have 23 to 25 cases overall. I mean, if randomly rattle out the list, it will be, as I already told you, 3 weaning failure, maybe ARDS, maybe obstructive airways disease, a trauma, primary, secondary survey. So, it's just going through that drill. I think that's very important. Another important thing in the practical exam is don't dive into the patient straight away. Whenever we have done exams, what we see is you give a problem statement, the candidate just jumps into the patient. Just pause for 30 seconds at the foot of the bed, or the what we call as the end of bedogram. That was what we used to call it in Australia. It's just that stay at the foot and glance around. You will straight away get a lot of information, vitals, what infusion is going, NORAD there or not, how many vasopressors. If you have a renal replacement therapy machine or a dialysis machine, maybe he already has AKI. Look at the ventilator settings, just a sort of a brief scan, and that will give you almost 40% of the information in addition to whatever the problem statement has been given. So I think these are a few simple tips which will probably also boost your confidence and save a lot of time overall. I think that's all I would submit humbly. And it is always good to be a pioneer. So all the new first-time DNBs, talking from my own past experience, I think you are the lead intensive care for the future. So I think I'm sure all of you would do very well. Thanks, Dr. Arindam and Rajesh, for the opportunity.
And Sunil, it took 20 years to get another more year, right? So from 2 years to 3 years. I think it should have been done a little earlier on that part. And I hope the guys are
universities for starting DM. Otherwise, we would have still be having an FNB all along.
And I think also Rajesh put a lot of effort to make critical care into a more acceptable. Maybe the pandemic also helped on that part, but I'm not very sure whether they still have 1 month of time. We have Dr. Bhubna who has joined, and she is from St. John's Medical College. She is the head of the Department of Critical Care. and she herself, one of the very privileged person who actually conducts all sort of exams. So she's the star, she's dazzling here. So she conducts the DM, hopefully she would be conducting the DrNB, as well as she does the fellowship exams for ISCCM. So one of the most experienced teacher and more so examiner. So we'll learn from her that what could be the possible format that national board may have come up with. So I would request her to, if there are certain secrecies that have to be maintained to be an exam center director. So barring that, if the certain facts can be shared by her to the candidates.
Thank you, Dr. Arindam. Thank you for the kind introduction too. So I guess the possible format for the DrNB exam would be similar to the fellowship exams or the DM exams. I think it should be in par with such examinations. So the initial FNB exams were, if I'm not mistaken, they were OSCEs, 6 cases which were pertaining to a particular system. But now going forward, where you have to have it, alongside DM, so we should have cases, which I hope that is the format that DrNB will follow, will be 1 long case and 2 short cases. So the total marks allotted, as I can read through the guidelines, is about 300 marks for practicals, which will include cases, stations, and the Viva OC. So it will depend upon the chief examiner to divide the marks as 200 maybe for the practicals and the spots, and 100 for the Viva OC. It is important to consider that, as Dr. Sunil has already mentioned, for long case, you may need to go into more depth in discussing, especially covering the basics and even generating differential diagnosis, identifying the key problems and how they would manage. So they would want to consider how you would work as a consultant. So that type of a discussion would be necessary in a long case. And short cases, they have mentioned a ward round. I was reading through some of the guidelines. One short case, maybe we may have to have it like a ward round. A ward round would be like you walk into the ICU and the first patient, you would examine like a consultant and take decisions. So one of the short cases may be a ward round, or they could be 2 short cases plus a ward round. We'll have to still wait for the format on what they would finalize. The spots and stations are similar to the, the other exams, even the IDCCM. So it will include radiology, which will be X-rays, CTs, ultrasound, echo, and even MRI, drugs, instruments, along with procedures, some key procedures that you should have learned while you're doing your training. And you'll need to identify the important instruments too. And there will be definite stations on hemodynamic and ventilation, labs to interpret labs, and along with ECGs and ABGs. I'm not sure if there's going to be a station on ACLS, or should we forego ACLS, because ACLS is already covered in, in the IDCCM. So we expect them to have been trained in ACLS, or the chief examiner of that center may want to have a station on ACLS too. Definitely, there will be a station on communication. So that will be definitely there. So that is something that the candidate will have to concentrate on, his communication skills and the medical, legal, and the ethical aspects along with it that will come. The communication can be as a separate station, or it could be included with one of your cases. The long case could have a section on communication, and then the examiner might want to finish off the communication. So that could depend upon the center. When it comes to Viva OC, there will be a table Viva. So that will definitely include all the examiners. So there will be about 4 examiners. So the Viva OC will be a combined Viva OC. At the Viva OC itself, there will be a paper appraisal. So the paper appraisal should be a part and parcel of the practical examination, just like how the IFCCM or the DM examination system has. There should be a journal paper or a paper appraisal. Thesis and logbook, as the DNB has already mandated, that will also be discussed during the Viva OC. So I think in short, this is what it is. It's going to be 1 long case, 2 short cases, and so many of these 6 to 7 spots or stations. It could be like an OSCE or it could be like a station, and a combined Viva OC.
I think, Sunil, anything to add, ask, or something?
No, nothing. I think just wanted to tell that when they present your case, when you present their cases, I think yeah, there is a brief complaint or presentation, then a brief history, perhaps examination at the time the patient came, examination findings. I'm just telling how the case flow should go on, because unlike MD, where you go with complaint, examination, etc., the critical care exam will be a bit different. So patients already admitted maybe 3 days ago. So let yourself divide this into the history of presentation plus whatever summary of the history. Maybe the examination findings from the case notes. Then you come to the course of the patient in the ICU, and then your current this thing. So after the two things, which is the history plus the course, give a pause. I think it's always good to give a pause, as Dr. Bhuvana said. Differentials are what we would want. So somebody with acute febrile illness and jaundice, or acute febrile illness with thrombocytopenia, there is a set of differentials that will be discussed. So give a little pause, then just see if the examiner wants to ask you some differentials or a few questions, because just don't keep on going on reading whatever you have written. If they don't get back to you, good thing, go on, and you can just say that on my summary, I think this is a patient with, say, acute febrile illness and thrombocytopenia, which I think are the following differentials. So that kind of a couple of places you may have to pause, and one possibly at the end of the total presentation. And summarizing it would mean summarizing in about 3 lines at the end with issues at hand. I think most important to say is, especially when you're talking about the long case, and if it is a very open-ended case which has been given without a specific question being asked, it would mean like a general intensive care examination is what is needed. So you'll have to summarize what are the current issues. So maybe the patient has significant PaO2, FiO2, which is very low, shock. This kind of summarize that these are the things, and then you can, even addressing that problem will be easy as the questions come by.
Yeah, but I think it's a brilliant tip, but I would first go to what Bhuvna said, that we have designed accordingly. So in this mock exams, we have 4 different types of long cases to make you exposed to certain different possible long cases. And we have selected long cases in such a way, because these sort of long cases are ubiquitous and almost always present in any Indian ICU. Right, so those would be the long cases. You will get the scenarios of the long cases 2 hours before the exams itself, so 2 p.m. Tomorrow. We have also kept 4 short cases, so that again you are exposed in that part. And as Bhuvna ji guided that radiology, drugs, instrument, procedures, and all these things. So we have divided the tables in 12 different category, right? So be it your ACLS, ATLS, and all others. So we didn't want to take chance. We wanted to test your ability in every possible way. So we have kept airway, ACLS, ATLS, drugs, procedures, equipments, devices. So everything in 12 different ways. And also we have added a separate communication where you would be asked to communicate in different aspects, whether it's an end-of-life care or organ donation or conflict management or consenting, everything on that part. But also 2 things, I think, which would be included into the Viva VOCI, which would all the examiners put together. Here, one study paper, appraising a study paper, as well as an assessment of your thesis and logbook. I think this would be included, which is routinely done in DM examination, where your dissertation is being actually assessed. So we have also kept that part in the mock test, so you know what are the questions you could be facing in the actual examination itself. And also for the radiology and other parts, can you mute yourself if someone? And also what we have also done is that there would be a quick OSCE. OSCE is objective structured computer-based evaluation. That means we will show you certain radiology, ECG, graphs, and screenshots of many different things, and you have to identify that. And that is how you would be also exposed to the possible radiology or graphics or screenshot. Those can be which can be present in the exam itself. So the mock test is basically making you aware that any combination of this can be present at the exam itself, so that there are no surprises for you in the upcoming exams. So whatever be it in a whether we have one long case or two short cases, and as well as one word round along with multiple tables and one grand viva where all the examiners are there, you are more or less prepared for any eventuality. And I think Bhuvnaji has given away a very good idea of what it is expected from you. And also what Sunil said, that it is little different than our uh, PG exams. This is a postdoctoral exams. Here and most of the time our critically ill patients are not there to give up sort of a detailed history. So history is always most of the times based on the summary that has been made by some of the residents, as well as whatever informations are there at the bedside itself, right? Be it your history sheet or your multiple different data that we interpret very quickly. So I normally teach my guys in a 4P format to make yourself. The first P is yes, that what is your provisional diagnosis and comorbidities, that you can write it down, right? So 1, 2, 3, 4, 5, these are your provisional or little bit of differential along with comorbidities. Then a little bit of progress so far. That means what had happened, what had transpired in the past days yet till at this point of time. What are the issues or problems at hand, right? The third P, that what Sunil was telling. So these are the issues like hemodynamic instability, shock, organ dysfunction, electrolyte disturbances. So these are the problems at hand. And what to do next? That is, what is the plan next? What do you do? So whether it is an intervention or some sort of diagnostic imaging and all others. So once you do it, analyze your case in a 4P format, then you are ready for the day. And also what we can say that in the 10-15 minutes of time, you can anticipate that what could be the questions it coming. Bhuvnaji, any comment on that? How to prepare in 15 minutes for the long case? Madam, you have to unmute.
Yeah. So for the long case, nothing. We need to be fluent with the chief complaints and and discussing the complaints in detail, plus summarizing the history and your differential diagnosis, and then present all the findings. As Dr. Sunil said, you stand at the foot end, you'll get a lot of information, and then quickly you channelize on what and all you're going to focus. And you make all your points and present it. I think the most important is fluency, and you highlight the key problems or the the findings that you have got in the patient, and your interpretation. I think a very important thing that I have noticed is there is no interpretation or the candidate's input on the finding. So that's also important. So they should interpret the findings and give the possible reasons that they think what they have found, in the patient. And ultimately, they have to, even in the long case, they will have to even look at the X-rays, the labs, and the drugs, along with cultures, and their input on or their interpretation on all of this too. So in the long case, if they have to complete it, it will have to come to a discussion on the management and the future plan for the patient. So that is very, very important.
I would ask Sunil to, he has certain other meeting. Sunil, please, some parting note. He has to another meeting to attend.
No,
and I would also welcome Dr. Pradeep Bhattacharya. I think he has joined somewhere in between, and he will be our next speaker. Yeah, Sunil.
No, I think nothing. I think most of the things I have already told. I think what Dr. Bhuvana said was very important. The word she used, fluency. I think many times, when as an examiner, we are watching the candidate go through the examination, we know whether this person has done it a million times or is doing it for the first or second time in the exam. I've had the good fortune and the honor of being an examiner with Dr. Bhuvana many times. And I think whenever we have done it together, we have without a doubt concurred that this candidate has done it, not done it, he will pass, he will not pass. I mean, when I say he or she, whatever. So, that way. So it's very, very clear often that this person has done it. So I think next 3 weeks will be to learn the dramatics of how we are going to do, how we are going to present. As I told you, passing a practical exam is half knowledge, half skill, and also how much of practice which you have done. As Dr. Bhuvana said, you have to give the impression of the system. Say, there's no point in repeating what the nurse tells us, heart rate, blood pressure. No, that's not what we want. You would say there is shock in this patient, maybe septic shock, maybe multifactorial, or he has an alteration of his sensorium or a decreased GCS due to this reason. So every system should be comprehended and should be compiled as an impression and put forward, because that's what you would be doing as a consultant, and that is what you would be handing over to your consultant the next day when you're on, finishing your rounds or whatever. I think that, and all the best. I'm sure all of you will do well, and we are hoping to get 100% practical pass in the first DrNB exam. Unfortunately, we didn't have it in the first FNB, but let's hope it will happen in the first DrNB.
Thank you. Thank you, Sunil, and I hope you would be joining tomorrow for the mocks. Yeah.
Definitely.
Yeah. Thank you. Thanks for that. Bhupnaji, anything on that? Any specific instruction has also been given for the candidates? They have to carry their thesis and logbook. Anything else they need to carry to the examination?
I think that's also the most important is the format of the logbook is already been provided by the DNB board. So they should follow that format. So the logbook submission should be in that format.
Okay, and dissertation anyway they have already submitted that. That
Plus
has been
all
approved
the
by
proofs in that the logbook, I think all the evidence of all the courses, workshops that they have attended, and the papers or in the conferences that they have presented. So that also.
And that has to be also signed by the head of institution and others. Yes, so those are your standard things. So there should not be any lapses on that part, on the dissertation and others. And the hall tickets and others would reach you soon, guys. The national board have improved a lot on here. Yes, Sunil, you can log out. Yeah, and it is much more prompt than what we used to have, right? So it is much better now. But still, you will have, I think, a couple of weeks time. I think the hall tickets and others information would be disbursed post Diwali once the long weekends and extended weekends is over for the Diwali itself. So hopefully between 26th to 28th, I think that the letters will start going on, and the notice will also. Today is easier to communicate through emails and all others. So guys, be prepared. I think somewhere in the second week, the examination dates would be. Any idea, Bhuvnaji? Are you supposed to tell, or it is also a secret? Or they can have an idea that what would be the possible dates?
It's somewhere in November, second, third week.
Second to third week, yeah.
Or
okay, so there were
end it should be over.
Okay, and there were concern for that there is an edict part 2 on 9th of November, and there are certain candidates who are taking both the DrNB practical as well as the edict part 2. Hopefully that they should not collide. Hopefully, because it seems to be that around anywhere between after 10th to 12th, the examination would start. And many of the times it is seen that we are not very sure, but it could be a parallel sort of occurrence at multiple because if I'm reasonably sure there are around guys, you can tell me how many of candidates you are, because we have close to around 94 sort of registration for this mock test, right? And my estimate is somewhere between 130 to 150 people have passed. Any ideas? Any one of you can give an idea that how many candidates there could be? Any one of the participants?
So maybe
Okay.
you are right.
Maybe I am right.
Yes, because
Probably 130. Yeah.
because the admission
Someone
was around around 180 in the first batch, and results are matlab, maybe 130 के आसपास will be appearing. This is just a guess.
So calculative guess is around 130. So if we take 130 to 140 number, and Bhuvnaji, how many candidates you can examine in a day?
There are guidelines as per the DNB for super specialty. I don't think more than 4 in a day.
More than 4 in a day.
DrNB, not more than 4. So
And
50
to
is
run an ICU, and you cannot, normally it is not more than 2 days at a stretch you can take an exams. So,
So
if
8%.
At the most you can stretch up to 10.
Yeah.
If I say 10, so there should be minimum 12 to 14 centers.
Yes.
Yeah, 12 to 14 centers there should be, right? And nowadays what they are also doing is they're trying to collect, not to give a home center, but trying to give you a centers which are closer, so you don't have to travel a lot. So I think most of the reputed institutes have been approached, and there would be multiple centers, 10 to 12 centers in all over India, particularly in the major metropolitan cities and in the centers which are have experience of taking examinations, particularly both DM and DrNB or the FNB, and all the good reputed institutes have already been approached about it. So do not worry about that, whether there would be some surprising centers and all others. And do not worry about the examiners. They always, our intent are to make you succeed, or we wish you to succeed, but obviously not at the cost of the quality, because it is for your good and for the greater good that a person who is passing or who is acquiring a diploma or a degree itself has to earn it and has to qualify for it. So that is our day. Our intent is always to be fair to the process as to the candidate. Bhuvnaji, any comment on this, that whether we are pro the candidates or we are pro exam process?
I think most of the candidates know the answer. I don't even need to, because the trend has been that it is favorable to the candidate. Unless we feel the candidate is not safe to practice, it's only in such dire consequences we take a decision against the candidate. Otherwise, in all, I think we are all kind examiners, if I can state.
Any areas where a sort of mistake is being considered as a blunderous mistake, and that goes very, very oddly against the candidate? Any areas, like, for example, basics in airway or ACLS, something of that sort? Any area that the candidate should be very extremely cautious of?
Gross mistakes in decisions. I think that is something which can irritate the examiner, where it cannot be forgiven. Some gross mistakes in decision making, which can endanger the patient's condition, or any difficulties in communication, or the communication skills are not good. So unsafe candidate, or as an unsafe consultant, that's when the examiner is going to be, you have really irritated the examiner on multiple situations. That is when, you are at risk, at a very high risk. That's what I would say in simple.
That would be an. I can see Dr. Ray has also been here, Dr. Banamba Ray, who is one of the most senior most person in our critical and respected person in critical care society. Yes, sir. Bhuvna has given a very nice head start, and she has put up word that unless you irritate the examiner. So he had been examiner all through almost more than 2 to 3 decades now, sir. And what irritates and examiner itself? What are the don'ts that the candidate should not do on that part? Yes, sir.
Arindam, let me tell you, and it's a confession, that I do not get irritated. I never get irritated. Anything that Bhuvana very clearly pointed out, that the
no, sir, I can assure you,
examiner is also always trying to help the candidate.
Sir, I can assure you, Bhuvna is one of the most kind-hearted.
Very, very kind. Oh no, she has spoken so eloquently and so clearly and articulated so very well that I cannot agree with her more on this. But let me tell you, to get irritated, I think is a personality, right? There are few examiners I know in front of me also, they have got irritated. They have very, very been vindictive. I said, oh, he talked like this, and how can he pass or how can she pass? I think one blunder, if we give him a chance to rectify that and he does it, I think we are not very, very finicky about it. We do take that in our stride and ask the other questions. I think if he has done very well or she has done very well, we actually pardon them, right? We do not really go by that particular question, which I think he did not answer very well, and he was quite opposite to what I would have imagined. We do not really go by that, right? That is point number one. There are a few other things I think as I think Bhuvana has also clearly, even Sunil also has said so. When you are actually examining a patient, your clinical examination must be very good at the DM or DrNB level. I think if your clinical examination is very bad. Once I asked a candidate, he said that it is a mitral stenosis, it was the case, and he said that it's a mid-systolic murmur. I said, where did you check your systolic murmur? He said, right side of the sternum. Gave enough of hints, enough of indications. She would not actually change. What do you do in that case? That means she hasn't actually done any clinical examination. So I think these are some of those situations where you would be quite hard pressed to actually clear her through, right? I think this something which, if she would have corrected that, no sir, I'm very sorry, I made a mistake, and then she would have corrected that answer, I would have given her the pardon, right? So therefore, these are some of those things which you must be extremely careful. Your clinical examination must be very good. Nowadays, I see doctors do not put their hand on the patient. I think this is something which I have seen in the US many, many years ago, 30 years ago. Then I was thinking, how can you manage like this? But today I see that happening in our scenario also. I think you must be very, very careful. I tell you to palpate the abdomen, and you don't palpate it all right, and you palpate somewhere else. You keep the patient in the upright position and don't allow the patient to relax, and you start standing on the left side of the patient and doing it. This means that you have never done it actually. So these are some of those situations where you must not give an indication to the examiner that you have not examined your patient, right? I think something which you have to be very good in your clinical examination. Then I think Bhuvana talked about summarizing the case. When you summarize the case, we say that it is onion peel kind of thing. If you have given 2 minutes, you have been given 2 minutes to summarize in 2 minutes the exact crux of the issues, right? You do not have to speak on and on and on. In 2 minutes, you speak something. You have been given another 2 minutes, you speak something more, onion peel. You add another layer into it, right? like that you do that, and you must do all in small 2-minute summary. Everything important must be there, nothing unimportant should be there, or nothing important should be missed. So you need to practice that on a daily basis. We go and see a patient, then you as a resident, you should be presenting the case there. So if you are doing it all through, I am sure in the exam also you do it. You do not have to go with a degree of tension, stress, that what will the examiner ask. Examiner never goes to the examination or the bedside with any preconceived thoughts. Never ever. Whatever you speak, examiner actually picks it up and asks you questions or counter questions. So therefore, you should actually go with a confidence. That confidence will grow if you are actually doing that on a daily basis at the bedside. And you should not actually miss anything. So these are some of those things, but I think the examiners are never vindictive. I do not think that I have seen anybody who says that no, he did not answer it, how can I pass him? But yes, you have been given a lot of scope to rectify what you said if you have made a mistake. And if you have done it, I think examiner is happy about it.
I think one thing we need to, we have a separate session on clinical examination, a quick clinical examination. We will give you certain steps. So one of our colleagues will talk about that. But I would, with permission of Ray sir, I would like to add that there are certain basic rules before you approach on examination is the privacy, then infection control, which are important in critical care. And also always ask before examining, keeping the nursing personnel ready. If you are examining a female patient, right, it has to be do not elicit a lot of pain on that part. And always ask the clinical attendant or the nursing person whosoever there. And in ICU, exposure and all others, this could be quite important. And if the examination is being sort of done, or you are doing the examination under the supervision of an examiner, then you have to not only have to be quick, but you have to be quite methodical and covering all the places, including the back itself. Right. So we'll come to that part.
If I can just add one more point, Dr. Arindam,
Yes,
I think
please.
it is very important to introduce yourself to the patient also.
Yes,
Before you go in, that is something which the examiner will be watching. You may be at a disadvantage if you're going to another, another place or a state where you may not be convenient with the language to speak to the patient. So maybe you may need to take help of the bedside nurse to
so what we can
to introduce.
Can we say the introduction, permission to examine, then privacy, and then assurance, hand wash, then the temperature part. Your hand should not be cold. So a lot of times I have seen that after hand wash, people do a little bit of like this so that your hands are naked, or asking for a gloves, which could be also a good idea to go ahead and examine. Sir, anything to add? The prelude of examination.
Dara very correctly said, absolutely, Arindam. I think these are things which should naturally come to you. You have been doing it day in and day out. You cannot but avoid it. You will continue to do this. So if you are going for exam and you think that you should do all the more, you must be able to miss one or two things which will be noted by the examiner. You please continue to do it as a daily routine. And you will be able to do it in the examination hall as well. So therefore, that is something which is extremely important, no doubt about that. Thank you, madam, for giving me an opportunity to examine you. All those things automatically should come to you. Put up a smile. You relax the patient. These are some of those things which naturally should come to us, and it is being watched by the examiners. So these are very, very nice etiquettes that you could actually practice on a daily basis. Please continue to do it for the rest of your life, and you will not have any problems.
And many times we do get a patient who is unconscious and not being able to give. Bhuvnaji, any on that, advice on that, that how they should, whom they should ask about the permission or eliciting pain response or something?
No, if patient is unconscious, we take it as a log of wood, and patient is not listening, and we can do anything we like to. That is not correct. Even if it is GCS 3/15, you still think that he must be registering what you are asking or what you are doing to him. So therefore, you continue to do that. But if there is a relative who is actually available to you, you must actually ask him that I would like.
I have seen, sir, and Bhuvnaji, that candidates I've seen in Europe, the candidates are asking the clinical attendant or the nursing person that
Yes,
can I
yes.
elicit a pain response?
Yes.
Can I do a
Absolutely.
exposure and do a
Yes.
in-depth
Even to
assessment or
expose the
examination?
patient, we will have to ask. Sometimes the nurse may not like the patient to be disturbed. She would have just positioned the patient. So she wouldn't want, the position to be changed. So I think it's very important to ask the nurse or the bedside clinical attendant, can I change the position? Can I expose the patient? And take their help to do it. I think that's
Even
very
to the same patient, even if she is or he is not listening to you, you think you should always seek his or her permission that I'm going to give you a little pain. It will hurt you a little bit, but nothing I'm going to do beyond. I will just do it for once and leave it. So you will not have any problems thereafter. But now you may have a little pain. I think it is always necessary to make sure that you are talking to somebody who is living. Whether he is unconscious or conscious is immaterial. I think we must presume that he must be registering something like this in his brain somewhere. And it is true, because I know that 2 months somebody remained unconscious, and when she woke up, she said everything that I have spoken in the last 2 months, right? I think you should take it that way. You should not think that somebody is, unconscious and doesn't listen, doesn't register. I think this is a fact.
Sir, also I think at times we have to be careful and safe for doing an examination, particularly in terms of devices, lines, and tubes, right? Because many of the patients will have multiple devices and tubes. So when you are exposing or turning or examining and all others, you have to be safe. And multiple times you can ask the nursing or attendant person that is it safe to go ahead, is it safe to do, and all others. So this would be very, very minutely observed by the examiner, that you are also safe to the patient itself. And so that caution and all others, and as sir said, that you have to give certain directives and assurance to the patient as well as the nursing person that everything is going to be fine, and you are not going to disturb or perturb the overall physiology as well as the well-being and comfort of the patient while you are trying to examine that part. And lastly is that you have to restore whatever you have done on during examination. You have done nothing wrong, right? But you have to pull this small gestures of yours actually brings a lot and lot brownie points for you. So you just adjust the blanket, right? Reposition the patient, help the nursing person to again restore the position. That's all. So that indicates that you care for the patient as a human being also, not only as a doctor. And you are actually you have that empathy to be a good doctor. Bhuvnaji, any comment on that?
All points are very important. I think that bedside etiquette is very, very important. As sir rightly said, it's a daily practice. That's what we are doing. We just have to do it as comfortably and not forget what we would do every day. I think that's very important.
Okay, so I would now invite my colleague, Dr. Tushar Parmar, who works with me in SRH and Reliance Foundation Hospital, and who himself not only a good intensivist, but an extremely well-established and good clinical physician also, right, along with an intensivist. So I thought he would be one of the finest people to talk about that how quick an examination can be conducted during the DrNB exam process. As we are doing an online examination, we have done a offline and on-site examination, mock examination, but with limited number of people. We have emphasized that. So he is going to give a tip of how to conduct very quickly the system-wise and general examination, so that all the points are covered.
Arindam, can I take your leave for now?
Sir,
I have got few more
one
cases.
Sir, then I would ask Tushar to wait a while. I have one or two questions from you. One is that regarding.
Okay.
Can I leave, Dr. Arindam?
Bhupnaji, you can, you had to go back. And I would request you to come back as promised by you, that you would be taking certain exams in both the days. So according to whatever we have discussed, and thanks for giving us all the information. And I thank you on behalf of all the candidates also.
Thank
Sir,
you.
before you take a leave, sir, I would ask that what is expected from the candidate on the dissertation or the thesis, and any tip for candidates for this appraisal of a study paper. Tushar, my apologies, sir. Just sir had been here. So once sir, you will.
You know, the dissertation, I can tell you this, that when you come to the exam with your dissertation, you have got to be absolutely thorough about this. You are expected to be thorough, obviously. So they can ask you anything. What is the objective of your study? Your objective may not have been a perfect objective in so far as the examination is concerned. There may have been certain flaws. Please remember that. It may have been passed by the national board, and national board passes it if it has been passed by the local hospital. Local hospital, the scientific and research committee and the ethics committee are not always, I am saying not always, it could be still quite all right, but not always. And in fact, most of the time I have seen that they have not given a very serious thought to the aims and objective part. Okay, so that there may be flaws in that. If they ask you, this is the aim and objective, it may not be matching with your conclusion. If it is not matching with your conclusion, more often than not, we have found that it doesn't match with the conclusion. You are actually in a little bit of a problem. So please, I think you look at those areas and make sure that your aims and objectives have ultimately matched with the conclusion. You know, what is the research question that you set out with, and what have you found? If they are actually negative or positive, it must be very, very clear. That is point number one. Number two is your primary objective and secondary objective. You know, people have a lot of confusion. What is the primary objective? What is secondary objective? Primary objective, say for example, primary objective is say death within 28 days of the hospital, in the hospital, or 28 days hospital death. Secondary objective could be the number of ventilator-free days in the ICU, the number of, length of stay in the intensive care unit, whether there has been a readmission into the intensive care unit, things like that. It has got to be that. The primary objective being a very important event, complication, and the secondary objective could be there are certain process parameters. You must be very clear about primary and secondary objective. Then comes to your material and methods. Material method is always imperfect, I have found. You give me any material method, I will find that there are some imperfection in those materials and methods. Your grouping may not be quite all right. You may have already completed it. It may have been accepted also. But there still could be certain flaws which examiner might pick up and then ask you. You should be in a position to tell that, right? Then your observation and results. Observation and results must be commensurate with your material and methods, right? It cannot be outside it. Observation and results, while you are doing the results, I think your discussion have got to be on the basis of the results and observations. It cannot deviate away from it. If there are studies, which are published in that particular aspect, those studies, when you are analyzing, which way your study is different from that. Whether you can accept those studies or you do not accept because of these reasons, whether what are the flaws with those studies or what are the flaws with your study. I think you have to be extremely clear about it. Once you have done that, I think you are through. If you are very clear about it, you are actually through. And then comes, of course, anything else, Arindam, you would like to ask on the dissertation?
Sir, on this table, we have how to analyze your thesis. So we have actually divided into 5 parts. One, as you said, that aim, objective, design, numbers, how we have come to that, the numbers that in the name. Second would be your methodology and obviously the objectives that you have chosen and all others. Third, that we have asked that the examiner would be asking on analyzing on the statistical methods and whatever the results, inferences that have been there. Then fourth point, that we would be in depth discussing that what is the overall, whether your results have corroborated with the aim that you have started with, and what are the critique of those, and what are the drawbacks and sort of advantages and drawback of the study you have done. And lastly, that the relevance of the study in context with the other parallel studies or the counter studies, whether your study is in concurrence with the similar nature studies and all others. So what is your knowledge about that? So this is the overall 5 different points. So some points initially on the methodology, as well as your intent of doing it, as well as the statistical understanding of your the dissertation itself. And second is your collateral knowledge about the subject that you are actually doing research on. Also, that would be covered mostly in your references and others. And standard things would be obviously looked upon by the examiner, that whether you have mentioned your references properly, whether the punctuations are good, whether your statistical method applications are correctly done and all others. But mostly these are all being rectified during your process of building up the thesis itself, as well as your guide definitely have guided you properly to do that. And once your thesis has been accepted by national board, so we as an examiner, we know that many of the times, so these are already being done. So this is it, sir. I don't.
Yeah, see, there is another point, Arindam, which I have found while evaluating this thesis projects. You would have written so many things in the introduction, and lot of these discussion elements are also incorporated in the introduction. Okay, and the introduction is actually something which is to back up your concept. So that you come to an aim and objective, so that you want to actually study something on the basis of the introduction. But the findings that you are going to find and the literature backing up those findings could not be a part of the introduction, which is why I find this is something which I have found in almost all the dissertations, right? I think every dissertation, I'm so critical, hardly out of 10, maybe 1 or 2, I actually clear it in the first attempt. So this is something which you have to be extremely careful. Okay, this is about dissertation. About the thesis, the research paper that you will have to analyze, again in a more or less similar manner. You need to be doing that evaluation with a magnifying lens, trying to find out what are the flaws in that particular research paper. You need to find out right from similar, the aims and objectives, the abstract, the introduction and everything. And of course, the research, the results analysis and the material methods. I think whether they are absolutely appropriate. Even like take, for example, number needed to treat, whether it is the right formula that you have adopted, or it has been just like that, right? Or whether it is a meta-analysis, or whether it is an observational study, whether it is a randomized control trial or the multi-centered trial. I think you need to you need to be extremely critical about it. Whether it was the right thing, whether the results that they have found is actually appropriately interpreted compared to what the material methods and the observations that you actually got. I think there will be a lot of discrepancies there. So therefore, the research paper also is similar, but you have to be sitting with it with a magnifying lens to find out the flaws with it. And if there are certain good points, you certainly can say that they will ask you, what are the pluses in this particular paper? And then you say, you find out what are 1, 2, 3, 4, 5 excellent observations that you have found. And these will be the pluses. What are the minuses? These are the minuses. Whether the conclusion is again matching with the aims and objective. If it is not matching, often it doesn't match. If it doesn't match, you speak it out. It doesn't match. Whether the data analysis has been properly done. So that is all that you actually do also in the research paper as well. But research paper, you get hardly 1 hour maximum. And 1 hour also, there is something else you are doing in that. So you have to be very, very particular about it. First, read out the abstract, what they have found out. Then read out the conclusion, read out the aims and objectives. You do this first and then subsequently go into the analysis. I think if you do that, you will be doing generally well in the viva on the research paper.
I welcome Dr. Deepak Govil, who is one of the directors in Medanta Hospital, as well as he had been our chancellor and president of Indian Society of Critical Care Medicine. He had been examiner for more than 2 decades now. And also he has formulated the examination process for the society itself. So, and he is also part of the national boards, many of the projects, including the examination. Sir, we have just started at around almost an hour now.
Arindam, just a little apology. Can I move?
Yes, sir. Yes, sir.
Thank you very much.
Thank you, Pranam. Sir, you will be there
Pranam and Deepak, welcome and have a nice time. It's a fantastic experience.
Yes, sir.
Thank you, Arindam. Thank you.
Sir,
thank you.
But you would be there for tomorrow and day after tomorrow, sir. For the exam.
Tomorrow day after I will be there. You tell me which time I will be there, sir.
Sir, I will WhatsApp you on the time.
Okay, fine.
Thank you, sir.
Okay, bye.
So, Deepak, sir, we had discussed about the format, the possible format, as Bhubna has been kind enough to discuss certain things. And also we discussed about that, what is that expectation from the thesis and the research article. We had a thorough discussion on that clinical examination is important and what are the preludes to conduct a clinical examination. My colleague Tushar is going to, after your part, Tushar is going to give a very quick idea about how to conduct a clinical examination after we have done our basic part of privacy, hand wash, infection control, safety, and all others. So my humble question to you, sir, the first one, the quick one, as a continuation of what Dr. Bonambar has said, that the critique of a paper itself. So in a examination, what are the papers that normally you do select as a chief examiner? The common ones or the important ones, sir? And whether the candidate gets enough and adequate time to read through it. And the third question is whether this is a critical appraisal or an overall general appraisal. Are we only to find out the faults itself or to overall analyze the paper itself?
Look, selection of paper depends on the individual examiner. What I do in National Board exam or IFCCM exam at our center, that we select 5-6 papers which are important papers in last 2 years, not 3 years, mainly 2 years. And then we circulate it all with all the examiners for their concurrence. Once they okay, then we put those. But mainly the trend is to select those papers who are either practice changing papers or who are a landmark papers. So generally, they should be selected. But again, it depends on the local teacher and local examiner, specifically local chief examiner, what he is selecting. Coming to the what you have to do for that paper, generally that paper is given in during between something. So like morning they will give the paper, and then during the between the two vivas of two cases or anywhere wherever you get time or the lunch time, then people go through the paper and prepare it for exam. In examination, mainly it is not the fault finding thing. So don't think that the critical appraisal means the fault finding in that particular paper. What I feel, in so many years I have seen majority of time that paper is taken as a symbolic. An examiner starts asking about the everything means if I start with any paper, it depends what type of trial it is. So then examiner starts asking, what do you understand by double blind or something, or cohort study, those type of questions. I'm just giving few examples. So what type of study is, then it comes the methodology. The moment methodology comes in, then the examiner starts asking many times that what is the common thing in methodology, how you calculate the n. Then comes the statistical analysis, then few questions about the statistical analysis, and so on. So sometime good 60-70% time the exam is not pertaining exactly to that paper. It revolves around the research methodology overall rather than a particular paper. Of course, everybody would like to hear what you think about that paper, what are the strength of that paper, what are the weakness of that paper, and by going that study, would you like to change your practice or not? If you would like to change your practice, why? If not, why not? So basically, it revolves around the strength and weakness of that particular paper. But of course, the moment you are given a paper, you should be prepared to tell basics about the basics of all the research methodology, starting from the type of study and then the statistical analysis.
So basically, sir, if we take a clue from your suggestion that if the candidates are actually aware of the studies, if we can stretch up to 5 years, there won't be many number of papers which had been very, very important and practice changing, or we can say a landslide paper. So it won't cross more than 15 to 20. So if you are aware of these 20-25 studies, and you can find it out yourself, you are a big group now. We have created a WhatsApp group. You already have a Telegram group. I'm absolutely sure that you guys won't get a surprise paper. Something very obscure paper won't be chosen. So those would be all papers which are important in the practice, which are quite famous for their own good, and they would be selected, and there would be surprises. And now you would know that what to expect as a question itself. We later on, Dr. Anirban will also join, and he will give you a quick overview on the statistics. But I would rather ask Dr. Govil sir, as he had been chief examiner as well as the examination process maker for so many years, that what could be the possible long case scenarios that would be included in a very important exit examination like DrNB or DM. Yeah.
So long case scenario usually are those scenarios which are involving multi-organ. Usually for short case, we keep a patient who is having single disease, but the moment there is a multi-organ involvement, then it comes under the gambit of long case. And long case can have anything like ARDS on ventilation. Somehow I feel that ventilation is an integral part of long case. So patient should be on ventilation with one organ or two organ involvement, especially if I talk about the two organ, then patient may be on vasopressors or maybe on a renal support, and otherwise the primary pathology along with the ventilation. So if we talk about, it could be a ARDS patient, it could be a multi-organ failure patient due to any reason. Or
so
trauma,
ARDS and
polytrauma,
sepsis.
Sepsis, yeah. ARDS, polytrauma.
Okay, sir.
But in long case, we generally feel that there should be multi-organ involvement, not a single organ.
Fair enough, sir. Anything on the neuro or pancreatitis? Are those common in
pancreatitis is also multi-organ disease. Neuro, I have already said, the trauma part is there. Trauma patients are mainly, sometimes stroke is also being given, ACS, acute coronary syndrome. There are like, if we talk about, there are close to 30 odd patients, 30 odd diseases which can be covered in the long cases. So what I would suggest that if you talk about from head to toe, entire critical care will come into 30 or 40 odd cases. Rest all is the combination of those cases. So if we talk about the cerebral system, there could be a head injury, there could be subarachnoid bleed, there could be hemorrhagic stroke or stroke, thromboembolic stroke, meningitis. These are the common in head. In chest, if you come down, the pneumonia, ARDS, viral pneumonia, bacterial pneumonia, pulmonary embolism. In cardiac, mainly the ACS or cardiac acute heart failure, they are the commonest one. So those type of cases, like if the patient is on pacemaker, I would keep that patient as a short case rather than a long case. So long case.
So we'll come to the short case separately, sir.
Yeah.
And anything on the GI, your like SAP and then your DCLD maybe.
GI,
DCLD.
GI bleed, liver disease, chronic liver disease, liver failure, and pancreatitis. Then, if it is a surgical unit, then you can find the intracutaneous fistula, patient having multiple surgeries, those type of cases where the patient is on ventilator, malnutrited, short gut syndrome type patients. Pyelonephritis can be there.
Okay, so
then
pyelonephritis
in the neuro, we have missed the Guillain-Barré
syndrome. AIDP,
Guillain-Barré, those type of transverse myelitis.
Transverse myelitis is not that common in the segments of
and Guillain-Barré is
sort of because you see, unlike the your online examinations, as these examinations are going to be happening in different hospital setup, so we would be only putting up patients which are there with us. So the candidates can easily calculate what are the common
it depends
patients.
on the seasonal variation as well. Like this time, at this point of time, the dengue hemorrhagic fever, dengue is quite common. Dengue ARDS, dengue liver failure, quite common. This is the season. So if you go to any medical ICU, I think 4 or 5 patients, 10 to 20% patients will be of dengue related.
So that could be an important clue, sir.
Yeah, so that is an important.
So thing. Dengue, malaria should be read by all the candidates. Yes, sir. I thank you for the clue itself on that part. Sir, do you think you work in a institution where there is a huge amount of transplant or patients? So normally acute transplantations are not included because we don't want to disturb them on their A, and they are, for ethical reasons, they are not A. But maybe transplant recipients who are coming back with certain infections or certain complications, are they're included at times?
Generally not. HIV and AIDS patients, they are included, but transplant patients generally not, unless they are coming with some other disease and some rare disease like which we don't see otherwise, like cryptococcal, those type of diseases. If they are there, sometimes they keep, but otherwise is a general tendency to segregate those patients away and not to expose them to multiple students or anybody.
So the patients who are themselves at risk on exposure, or patients who are risk to the candidates itself, those would be avoided.
Avoided.
So both ways we avoid.
Institute, if they are not finding any patient, then they can keep anybody.
That's an issue, sir. And lastly, we have covered cardiovascular, GI, trauma, neurology, sepsis, then pulmonology, and a little bit of tropical fever, maybe at times immunocompromised or transplant recipient, but much stable and who are not at risk of on a major part. Sir, what about poisoning, burns, and all others?
Poisoning burns in, if the DrNB center is in a big corporate, it is difficult to find a poisoning or burn patient. Many of the corporates which are in the top centers or in a metropoles, we hardly see any poisoning or snake bite or those type of patients. But of course, if we are having some centers at the little bit rural
Medical
area,
college, medical college are being put as a center.
yeah.
So that would be a very good suggestion and advice from Deepak sir, that if your center is a medical college itself, right, with a huge volume of patient, so you can pretty well expect some certain common poisonings and or a snake bite or a complication of snake bite itself on that part. So you can just brush up.
But I am sure if I am having any poisoning patient, I would like to keep that patient in examination.
As a maybe as a long case, yeah. So just we can put it as a the overall ideas of general poison care can also be evaluated from the candidate. So if you have, sir, what about nowadays mechanical devices are quite pretty common, particularly ECMO, IABP, and all others. So would there, and you would be using a lot of and your center is common for a DrNB center also. Maybe your center is being selected for the exam itself. So would you like to keep a ECMO as a part of long case itself?
Yeah.
So yeah, a patient on VV ECMO, VA ECMO, or both?
Not VA,
both
generally VV, not VA.
So VA ECMO generally would be avoiding because that is a little more specific for the cardiac and maybe
subspecialty. It is more specific for subspecialty rather than a general critical care.
So, so sort of VV ECMO as a part of your ARDS or respiratory failure management. So that would
even IABP, I would like to keep in the exam. Heart failure patient or something.
Right. So, guys, you have to be ready about that. Not only on the procedures or Viva OC, but or the tables, but on the long case, there could be all sort of organ support. So be it your RRT, be it your IABP or VV ECMO. So everything would be included in a long case, which could be an A. And as sort of Bhuvna gave an idea that there would be one long case, at least, maybe it can go up to 2 depending upon the center itself. So you guys be ready for that. Sir, regarding the short case.
Short case is an organ specific case, like simple if I talk about the COPD patient with acute exacerbation, maybe on NIV, not on ventilator. With ventilator, we'll keep it as a long case, but on NIV, COPD can be a short case. Then, as I told, the complete heart block with pacemaker, temporary pacemaking could be a short case where the VIVA is restricting to one organ mainly. That are mainly the short cases. Sometimes like hyponatremia can be a short case. Hyponatremia, those type of patients, electrolyte abnormality, metabolic disorders, they could be a short cases.
So electrolyte abnormality, metabolic disorders.
Yeah, weaning failure.
Yes, so I think weaning failure is a sort of where we can discuss a lot of things. Anything on the infectivity, sir, particularly sort of infections which are nowadays a menace to the big corporates like or Candida auris or infection like Stenotrophomonas or Elizabeth. Can they be included?
I'm not sure. It depends individual's choice.
Okay, sir. Sir, what about if there are certain patients like which are not very common here? One is not very common to the ICU in general, the populations, like pregnancy.
I would like to avoid such patients. I would like to avoid, because my idea is to assess patient on the common ICU patients rather than a rare patient.
Okay, sir.
But it depends on the individual's preference. Sometimes few teachers feel that we should keep one surprise, but I don't want to keep that surprise.
Okay, sir. Regarding oncology and post-op, can they be included, particularly patients on pain management, parenteral nutrition, something of
parenteral
that
nutrition pain management, we generally don't keep pain. Parenteral nutrition, I generally keep for reserve for medicine patients, medicine students. When DNB medicine they come, then they are coming to ICU, one or two ICU cases, short cases are there. That time we keep those type of patient, but I don't think so in DRNB specifically in parenteral nutrition will be asked as a short case. Parenteral nutrition will be discussed in the long case, I am sure.
Okay. No, I was thinking that we can keep a perioperative management as a short case, which includes all this type. Anyway, sir, oncology patients, anything on that? Any specific, if there are situations, or no, they come as a general issue?
They come as a general critical care.
Okay, sir.
Because
Anything on the yes, sir.
Like TTP, HUS, those type of things can be there if somebody is having.
Okay, so hematological emergencies can be if there are so.
Yeah.
As well as
obstetric cases, it depends, Dr. Bharat, in hospital to hospital, which hospital is having. If the hospital is having good sort of obstetric cases, they will be definitely there. Like everybody, I would love to have in examination preeclampsia, eclampsia, those type of, or hepatic liver failure, fatty pregnancy liver failure, those type of patients. But it depends on the hospital to hospital and what they are having at that point of time.
okay, sir. So any question to Deepak, sir? I think we have extracted most of it. Tushar, you want to ask something? The candidates, anything you want to ask, sir? Okay. So, sir, I know you have just come back from Toronto itself. I hope you had a lovely experience over there, and we hope best. Someone has asked that about the time. What is the time for case discussion?
No, there is one more thing is in obstetric case that
The sir has answered that if there are good, I think this is good for A. So there would be, I think, if there is a PIH or something of that sort, that goes to long case, or a short case in the as an your HELP or AFLP or any other. And also, I would add that extracorporeal therapies, if there are being a, they can be put into as a short case. So these are the areas. We will give you a exhaustive list. We have noted it down, and we will also add some on that part. Sir, how much time is being given for analyzing the patient and examining the patient before the cross-examination do start?
20 to 30 minutes.
20 to 30 minutes. And how much time would be given to the examiners to cross-examine the candidate?
Same.
So 20 to 30 minutes for the candidates to prepare themselves.
Same time.
Before, and a similar amount of time, around 30 minutes, not more than 30 minutes, not less than 20 minutes for the cross-examination. And there you can be asked.
I would suggest all the candidates to kindly prepare your final diagnosis in a single line and start with that I feel that this patient is having blah, 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 10 things, rather than starting story. Majority of time, people start reciting a story. That patient was admitted in one hospital with this complaint 10 days back, 5 days he was there, then he shifted to this place, then blah, blah, blah. So out of 20 minutes, he or she wastes 10 minutes in this type of a story as well. A story of the history, what we call a history of present illness. History of present illness is important part of any cases, but it is again one of the important parts. Every examiner would like to ask what is your differential diagnosis, how you are excluding different differential diagnosis and pinpointing one diagnosis. That is the first and foremost thing. And that is a practical part also. If any patient is coming to your ICU, first of all, you have to think what is the problem in that patient, what could be the differential diagnosis, then how you rule out a rule in each diagnosis. So what investigation would you like to send and how will you manage? That is the complications do you foresee, rather than what I have seen many times, the student waste time 10-15 minutes only in reciting the history of present illness, and I feel that is going to be waste.
Fair enough, sir. Sir, last question before I relieve you from it, because you had been a busy schedule. One is Sachin is anyway giving us an idea of whatever the critical care ultrasound that we need to cover. My very direct question to you, would you give, because we do not know about the DRNB structure as of now, but would you like to give a ultrasound machine and ask a candidate to demonstrate certain abilities to?
As my information is, only 2 or 3 centers in India are doing the same thing. I don't want to name those centers because things can change in those centers, but that is what I have heard. If I had to do, I have till date, I have not given ultrasound to any student to demonstrate different sign or symptom.
Okay, so but it's no harm to, because I'm reasonably sure that all of the DRNB candidates who are going for the exams, they are well trained about it. If not, they're trained by you, right? And they have the basic skills to do the simplest of things, right? So whether it's an IVC assessment or knowing about the pleural effusion or the B lines or a DVT demonstration, I think this basic things has to be a basic idea of the nomologies and the probes that can be easily done. So someone won't be asked about go and do a very complex diagnosis, but some basic things can be asked, and I think guys are ready to do that. What do you think, all the candidates? Are you ready to do that if that is being asked? Some answers, please. Random answers. Yes, so someone said yes, and I hope so that you are representing the entire cohort. So thank you, sir. And I would request, if you get time, tomorrow and day after tomorrow, we have 2 mock examinations. Tomorrow is
tomorrow. I am traveling actually. So
sorry, you are going to Paris.
Yeah.
Okay, sir, have a nice flight, and I hope you would be kind to our candidates, even there is an examination center in your place. Thank you, sir.
Thank you.
Sir.
Best of
And
luck
have a
to all
nice
the
day.
candidates. Thank you very much.
Okay, so now I invite Dr. Tushar Parmar, who is going to give you a quick review of how to do a examination part.
Good afternoon, all.
No, I will log out. Or you log out, you do it from here. Huh? It will always do that.
Good afternoon, all. Today, our topic of discussion is how to do a quick clinical examination. So, more or less, our entire exam is based on a quick clinical examination. So, for any case, when you are there, you won't be able to know the entire set of history, entire set of problems what he is going through. But we need to directly be specific on what we are dealing, what is the exact problem, what we are going through, and what should be the immediate solution of it, or any other acute complication what we are dealing. So to summarize this thing in a short, there are 2 ways where we need to go about. There is one is an initial assessment and initial management. Then once the management part is over, then here comes an secondary assessment, secondary management, and pertaining investigation about the same. And once that is over, probably a diagnosis as well as the confirmed treatment. So this is how a typical chart of a critical illness goes by. If a patient comes to me, how quickly I assess the patient about my ABCDE, that's a primary part. And how I manage my ABCD, that's the primary management. Once I go down below that, probably my secondary part will start as a secondary investigation, that what exactly am I dealing with him? What exactly am I dealing with the disease process? and pertaining to that, what investigation I can send. And when this is over, you try and go to the third level where you are treating actually the cause of his presentation. Typically, when you be into an exam, what things what you look into, your patient is already in the intensive care unit. More or less, it has been diagnosed that patient is having such kind of a disease. What you are given to is a case scenario about what you are going to observe and what you are going to present. In my opinion, what we require to do in that situation is a quick clinical examination about your patient and the surrounding. When I say about the patient, we need to go about from top to bottom. How about my neurology of the patient, whether my patient is awake, conscious, GCS, or whatsoever. When I go down below that, how about my respiration of the patient, whether he is using an accessory muscle, if it's COPD, whether he has a tachypnea, tachypnea, and he will having in bradypnea, or any other sort of a respiratory illness we are dealing with. When I go down below, then an examination of abdomen, just a palpation of abdomen will tell you whether my abdomen is tender or anything else. If I go and see about my patient for the monitor, my heart rate will tell you most of the stories that what I'm dealing with. If I go and see if I have an art line or a center line place and CVP or an art line monitoring is being placed, I need to see what's the rhythm is about, what are the waveform is about, and how am I going to measure the CVP or whether my CVP has any implication or not. Still, when we talk about the environment, we need to see about my rise tube, my any ICD if placed, my central line is placed, my art line is placed, my Foley's catheter, and the color of the urine. So my primary assessment to an intensive care start with a different than what I start with any patient who comes to an emergency situation. Supposingly, there is a case who presented with an abdominal sepsis over here. If I go and check my patient, my primary assessment would be heart rate, whether it's on high or low, my blood pressure, whether it's on high or low, my respiratory rate, whether I require some amount of a support, respiratory support or not, whether I'm requiring any blood pressure support or not, and what sort of illness am I dealing with. When I see my abdominal sepsis is there, probably per abdominal examination, showing you a tenderness or a bouncing tummy, which shows that there is a possibility of an intra-abdominal source of infection. To you, most presentingly, may be either an operated case of something, or it may be an necrotizing pancreatitis with dilated distended abdomen, or you may be dealing with an abdominal distension because of an SBP, large ascites and a cirrhosis of liver. You need to focus your primary goal over there, that what is the first thing you are going to correct, what is the first thing you're going to address in that patient at that moment. Whether my abdomen is an issue, what should I do about the abdomen, or what care should I take about that? If my respiration is an issue, what respiratory care should I require, and what should I do to correct that? And if my hemodynamics is an issue, what are the changes can be done which can improve the primary problem what he is dealing with. This is more or less about when you enter and when you see the patient. Now, more or less, when we start any history taking of the patient, when we come to a secondary examination, we try and take a history of the patient. That patient is dealing with previous illness and multiple causes. If there is a relevant to your primary illness, then and then probably it is better that we should be correlating both the existing illness and the previous illness. That would be more elaborated. Taking a history for a longer period of time will actually reduce your time for a clinical examination, and you won't be able to get through so many things which can be done by seeing the patient or by examining the patient. So my personal advice for most of the people is that you go through the history portion of it, but definitely don't miss out the clinical portion, how you are going to do it. Now, when we look for the system-wise quick examination, is that if I go with a neurological system, I should be well versed with my pupillary examination. I should be doing my examination of my movements of my limbs power. I should have some amount of an idea about his tendon reflexes and superficial reflexes. I should have some idea about what is the GCS and what level of a drowsiness or what level of a comatose is am I dealing with. That is the basic and the simplest way you can just try and elaborate your case in that direction. Whether I'm dealing with a stroke, I'm dealing with an encephalopathy, I'm dealing with any other neurological illness, that has to be decided that way first. This quick examination should be a part of your initial assessment and then carry forward. Probably we usually don't go much deeper into very much clinical examination about neurology once we diagnose that this patient is dealing with a right-sided infarct or left-sided infarct. We don't go much into that discussion, but this all are the basic thing which we require. Similarly, when we discuss about the respiratory case, what we expect is that what is my breathing, how is my breathing, what pattern of my breathing is, what rate of my breathing is, whether I'm wheezing or not. If there is a crepitation, where are the crepitation? If there is a bronchial breathing, where are the bronchial breathing, and whether you can appreciate that or not. If there is a chance, we usually don't get the kind of a patient, but in the similar fashion, if the patient is ventilated, we should be knowing what are the things where you can diagnose the any untoward effects of the ventilation, like pneumothorax or any other pleural effusion whatsoever. If we are going into that direction, probably we should know how to examine in that scenario. So for respiratory case, I would still suggest that we should be knowing basics of wheezing, basics of capitation, basics of your bronchial breathing. And beyond that, we should be knowing to diagnose any of this case by either a bedside sonography or any other assistant device. This isn't probably a good idea how we can go forward. If I'm dealing with an abdominal issue, I should be knowing every bowel habits of the patient. I should be doing just in palpation of the abdomen, whether I am dealing with an tense abdomen, distended abdomen, there is a fluid thrill or not, whether I'm dealing with any amount of an hepatomegaly, splenomegaly, anything. Because in a case where tropical illnesses, you may be able to find some amount of an hepatosplenomegaly, and that would be an apparent on the similar side. Am I dealing with a previous issue? In that case, probably cirrhosis of the liver or any other illness probably may help you to guide that why there is a distended abdomen and why there would be some examination to be required. Moving forward, probably in our intensive care, we see a lot of NSRCAs where my legs are swollen, my genitalia are swollen. There would be a lower limb distension, there would be a lower limb swelling present. You need to find out any skin coloration changes, see for this any amount of an signs of an DVT, signs of any other cellulitis or anything else. So skin color and skin changes will also be helpful in determining any relevant clinical findings also. Moving forward, when we go for the heart, probably we see that there would be some amount of an respiratory element with a pulmonary edema, but heart rate would give you any arrhythmias am I dealing with, any heart rate related issue, what are the factors previously, whether he was in he has undergone in CABG or PTCA or whatsoever previous history may lead you toward the cardiac examination. In cardiac examination, stethoscope wise, I'm unsure that most of the examiner would ask you to go for the what level of murmur or what is going on. But yes, hemodynamic per se, when you are observing, If you are dealing with an art line, they would be they would prefer to ask you about how my waveforms are, what are the hemodynamics, and what are the changes what you would like to see, and what sort of treatment would you like to give in this kind of hemodynamics. That would be the basic questionnaire will be asked for the cardiac cases altogether. Eventually, when we move forward, uh, uh, possibility of us being into a situation where we come with an initial assessment, secondary assessment, and then a relevant investigation. So when we discuss about the initial clinical quick examination, you also should be knowing the relevant quick examination, quick investigation, like for the brain, what kind of imaging you want to go, like for chest, what kind of imaging you would like to go, or how would you like to diagnose it bedside. For the heart, similar way, what sort of changes in echo would you like to see, or what can be done, what should be your aim for fluid resuscitation, and what are the changes would you like to see. And similarly, what kind of imaging would you like to go for the abdomen, or what sort of investigation would you like to go for that? This is in general about most of the systems, what we are expecting and what we should be doing. At the same time, the disease process, probably when we discuss about sepsis or myocardial infarction or any pancreatitis or any neurological illness, possibility we going further in detail once we cross the initial assessment, secondary assessment, and then when we come to diagnosis. So like Dr. Deepak Goel told, that we would like to hear the diagnosis first. I do also opine for the same. We would like to hear the diagnosis first, but at the same time, what would you like to know from you is that with this diagnosis, what are the factors or what are the clinical signs you will be able to see over here, which are supporting your diagnosis or which are not supporting your diagnosis. So in case if you see that my patient is having an acute myocardial infarction and he presented with this, the supporting evidence would be any amount of an cardiogenic shock is there or not there, whether he has undergone any recent procedure or not there, whether he has some amount of an ECG changes or is there or not there, or whether we have any supporting blood investigation which shows that he is going through in some amount of a cardiac illness, which may be an MI, which may be an cardiac ischemia or any failure kind of a situation. So giving a diagnosis, giving a supportive evidence for your diagnosis is primarily important. For giving your supportive diagnosis, you need to be very vigilant about your patient and the surrounding of the patient, which will give you clues that whether your diagnosis is good enough, whether your diagnosis is any relevant with the patient or not. Any question from the candidates? Anybody? I can see Dr. Vivek here.
I'm there.
It was quite very aptly described and all others. So we have Dr. Vivek and Dr. Srinivas has also joined. So I will come to both of you, sir. Dr. Vivek Kumar is and Dr. Srinivas, I will come first because he has been there for a while, and then I will come to Vivek's sir itself. So my question to Dr. Srinivas would be, and sir, you are here, that there is a lot of data are being presented, particularly whether it is during the clinical examination and assessment of the patient previous to the long case, or even in the short case, some quickly within some few minutes, we have to make all those lab reports, the imaging copies and all others, then the information coming from the monitors and the organ support devices and all others. So how quickly and methodically we can interpret these data, assimilate, do a lateral thinking, and then quickly incorporate with the overall assessment of our patient as well as intervention that would be required. So how quickly and how methodically we can do that. I will also come to about this question to Dr. Vivek also. So let's start with Srinivas sir and then Dr. Kumar.
Thank you, Arindam, for having me in this very important initiative, and thank you for having me in the meeting. Yeah, so when it comes to data interpretation, you have to look at it from three aspects. First thing that is happening is what is the acute alteration in the data you are looking at. That is something you need to be paying attention to. Suppose you are looking at a patient with an hyponatremia. What is the context in which you are looking at this hyponatremia is the first thing that you should be looking at. Now, if you are given a clinical scenario, if you can actually suppose you are given a clinical scenario of an altered sensorium, you would see what the hyponatremia is currently the sodium is 110, for example. Then you need to look at the trends for the previous 48 hours. Has it been a rising trend or has it been a falling trend? Is this associated with any other abnormality? That will help you to judge whether this hyponatremia is the cause or it is an effect of the clinical problem you are facing. I'll put it in a very simpler way. Now, suppose you are looking at a patient with an altered sensorium, which is not explained by a CNS disease. You are now looking at the cause of the altered sensorium being traced to hyponatremia. So how do you, what is the grading of hyponatremia based on the level of sodium? How do you assess severe hyponatremia? And you can expect the next sequence of questioning to be happening in those lines. However, if you are looking at a patient who's had a problem, CNS problem in the past, and is now hyponatremic, you can expect the trend to go into the questions like syndrome of inappropriate antidiuretic hormone production and cerebral salt wasting. So you should be looking at the data which will corroborate or which will give you the clues to these entities. Similarly, if you are looking at a hyponatremic patient who is in shock, you can expect a questioning whether this is endocrine shock. So you should be able to look at the corollary data. What is the potassium of this patient? What is the blood sugar of this patient? What is the other hemodynamic parameters of this patient? And expect that the questioning will go into the replacement of steroids in septic shock or replacement of steroids in shock. This is one situation. The second situation you will face is in a clinical situation where certain abnormalities are expected. You are given a clinical scenario. For example, you are given a scenario of a postpartum hemorrhage, for example. So in this situation, what is the lab data which you need to assimilate or you need to anticipate to be presented to you either in the vignettes or in the next slides or by in the next questioning sequence by the examiner. So here you are looking at markers of DIC. How do you grade DIC? What are the components of the DIC scores is something you can expect. You need to assimilate that information from the lab data that is given to you. What are your transfusion triggers? See in the report whether any of the transfusion triggers are being met by the patient. Similarly, in the current context, all these patients who have some bleeding diathesis or who are looking at massive transfusion, please anticipate that a viscoelastographic line of questioning is expected. So please anticipate that the next sequence of questions will be about clot initiation, clot amplification, fibrinolysis. So be prepared with the data which will corroborate your hypothesis that this problem is leading to the X situation. Similarly, if you are facing a trauma patient, for example, and the patient is thrombocytopenic on ventilator with altered sensorium, several situations can be anticipated. The first being DIC, of course. You need to then be aware to look at paraphernalia of substantiating a diagnosis of DIC. At the same time, you can also anticipate a HIT syndrome, and you can also anticipate questioning in the lines of fat embolism syndrome. So what is the lab data and radiological information that is being provided to you corroborating into which direction you have the strongest positive factors and in which direction you have the strongest negative factors. According to that, you need to triage your answer and ensure that the answer for which you have the strongest positive answer clues is the first answer you give, and the ones which have the strongest negative aspects are the is the last or behind in your answering schedule. Arindam, is that what you are expecting?
I will come to Dr. Vivek if you need to add something, sir, and then comment. Vivek, sir.
Yeah, Arindam, hi, thanks. Can you just repeat the question once more? I heard it, but I heard it in the passing.
It's about that that the data interpretation. We are always given a lot of data, be it your investigations or imagings or your inputs from the monitors as well as organ support devices. So a candidate who has only 10 to 30 minutes, and then we will be giving them a clinical note. Then they have to examine the patient and also assimilate all those data, interpret them, put them into contextual situation, and then interpret in the final diagnosis as well as intervention. So how they can interpret them and do it within a specific time period.
Yeah, I think the most important thing is to presume that you are at the bedside and read the clinical note word by word with the aim and that you will not be getting a chance to read it again. First, pick up the clinical points, the relevant symptoms, the relevant signs. And then from the signs, you move to the next thing as the bedside, and that is the monitors. So after from the clinical note, when you have picked up the symptoms, the signs, the vitals, then you move to say the cardiac monitor, and then you move to the ventilator, and then you move to the arterial line, or if you have any other form of basic or advanced hemodynamic monitoring. And at every step, keep making three differentials and closing it in your head, so that by the time you are entering the labs, you actually know what to expect and what are your differentials. And then when you go through the labs, even if there are 10 labs, these are the three things I'm looking for, and this is what I should get. And then once you get what you feel is correct, you go back in the reverse order from the lab to the symptom and sign. I think that's the best way to close it at the bedside, rather than picking up an elevated alkaline phosphatase and then looking for this. So always start bedside, say patient of whatever, chronic weakness, fatigue, gray stools, and then has come in whatever reasons to the intensive care unit, and then has gone in for some form of, say, has come in with a septic shock, and then has gone in for a basic or advanced hemodynamic monitoring, ventilated. So by the time you finish the clinical examination, if the patient is ventilated, you should go through the ventilator settings. If the patient is on supports, you should go through the hemodynamics. If you're going through the hemodynamics, see if there's anything to tell you anything about dynamic measures over there, which is listed there. Okay, and after that, then if the patient is on other forms of organ support, just note the CRRT settings, okay, whatever is there, and then come to the labs. I think that's the best way. And this is day one, and then in such a trajectory, you can see day 2, day 3, and then put it in the same way. So say if it is a course, a patient who's on, say, has come with diarrhea and septic shock and then develops a azotemia, and day 3, the azotemia is profound, and then there is thrombocytopenia, so he's heading towards a TTP. So then you try to, in the trajectory, there will always be a syndrome. So the first presentation may not be syndromic, but the trajectory will always be a syndrome. I think that's all.
Thank you. So taking clue from both of you, if we can divide data, which is also which is important both in the cases as well as it can come in the tables or in the OSCEs, right? We can divide data into biochemistry, hematology, maybe at times histopathology at the end, because biopsy and other reports can be. Markers of organ function like renal function, liver function, coagulation function, and others. Urine analysis, which is at times be very important. So this become lab-based. Then we have images which could be static and dynamic. So the static images are, we start from the basic X-rays, then go up to CT scan, rarely MRI, which are included in the exams. If it is so, they could be the very basic, as well as the dynamic, particularly the ultrasound and echo, which are very important. Then some of the printed data that we can call off, like your ECG, EEG, AMG, and NCB, and all others, which could be both static and dynamic, normally static and others. Then your monitored parameters, right, particularly the respiratory, like saturation and EtCO2. Then you have your hemodynamics, like CVP, arterial line trace, PA catheter, continuous cardiac output, and all others. Coagulation function, be it your INR, ACT, or your TEG profile, and all others. And there could be some others like intra-abdominal pressures and lastly, you have the inputs that do come from the organ support devices, like the ventilator, the graphics, or the parameters that do come, with the peak pressures, plateau pressures, mean pressures, compliance, resistance, P01, and all others. The inputs that come from it, the inputs that come from your cardiac devices, like be it your IABP or your the pacing, or maybe the ECMO machines and others. And as Vivek had told about the RRT machine, so be it a CRRT or SLED, whatever information you do get. So this much of overloaded information is there. So only you would succeed if you are contextual, that you are analyzing in terms of, and you are anticipating that according to the case, these would be specifically looked upon, and also you are methodical and you are doing it regularly at the bedside. Dr. Srinivas, anything to add?
Yeah, so that's again, as I said, the time that is available for you in a bedside clinical exam is very short. You need to do a comprehensive collection of data that's going on around you. If it is a hot case, that means there is an examiner standing with you while you are examining and collecting data. It's always good to react to an alarm, right? For example, if you are examining a patient in an exam during the exam, and the bedside monitor beeps, or the ventilator beeps, or the dialysis machine beeps, please get the bedside nurse to attend to that alarm first. So that will actually show that you are actually paying attention to the immediate problems in an intensive care unit, because these alarms are meant to call for attention. From there, you get a lot of clues about what your basic problem for that patient is likely to be. So, and when you analyze the data, be ready with your thought process that should go in a proper stream. For example, if you are having a hypoxic patient, be ready with what is his compliance, what is his driving pressure, what is the PEEP that is being used, what is the tidal volume, how much is it coming to if you predict his body weight, and what is his fluid balance, what is his lung status, what is his cardiac status, what are his biomarkers doing. This thought process should be already going back, going at the back of your mind. Sriram, the question is, when alarm happens, can we troubleshoot it? No, you should call the local people to do the troubleshooting, because you are only there for the last 10 minutes with the patient. So you don't know what the trends are. You don't know the policies of the unit. So in the interest of the patient, you should call the registrar who is there to help in the exam, or you may ask the bedside nurse to call somebody. But you can, if it is a basic alarm like a ventilator disconnect, yes, you're supposed to disconnect it. But suppose a low minute ventilation alarm is going on, or a high peak pressure alarm is going on, call the bedside nurse, call the registrar on the floor to pay attention. Don't get yourself caught in that maze of trying to sort out clinical problems. But make note that this is an alarm that happened when you're examining the patient, and therefore this could be the problem. Make a note of it in your presentation. Arindam?
I would give a very funny incident, or I won't say funny. It was quite an uncommon incident that had happened. I was taking an examination and the candidate was there, and the next patient had a cardiac arrest. And the guy was so involved and engrossed with overall his work schedule and all others. and he immediately reflexively went to start CPR on that part. So I would take a clue from this, that if there are very non-emergent alarms or problems happening, you should draw attention of any of the attendants or your nursing person or even the examiners. And if it is a life threatening, you can act upon it and you can earn some brownie points and save lives. So that could be a good idea on that part. Srinivas ji, any specific, we have discussed till the time on clinical examination, certain long cases and short cases, then summarization and all others. I would just ask you, because you are one of the most person who is quite expressive and who can form the answers very well. So I would ask you, sir, that what is your tip to the or suggestion to the candidates, that how to form the answers, how to give answers which are to the point, well structured, covering all the different aspects of what we trying to express, and yet within the time frame, and yet not very long. How to do that?
Yeah. So the thing you need to remember is that whatever you have read, you cannot convey that to an examiner in that 20 minutes of conveying. So what happens is you tend to give the most exotic and the most exhilarating diagnosis first, right? Some examiners don't like it. So as it was written in Chamberlain's clinical methods, when you hear hoofbeats, think about horses. Don't think about giraffe and zebra. So the first answer you should give is the most common, most likely problem. So grade your answers according to the probability of it being the most likely answer. That is the first point. The second point is every answer you give should be backed by hardcore clinical, biochemical, microbiological, and radiological data that you have in your hand. There cannot be an answer which is at divergence to what you have in your hand. That is the second point. Third point, when you give these answers, there has to be some robust published evidence or guideline which you can fall back on to quote when if that answer is questioned. For example, PEEP, for example, recruitment, for example, prone ventilation, for example, balanced crystalloids, for example, steroids in ARDS, for example, hypertonic saline in, for example. Whatever you take, there should be some, if somebody questions, why did you give me this answer? That data, the evidence should be at the back of your mind. If I give this answer, this is my data. And always in a critical care exam, give the pressing problem first, the situation, the background, your analysis, and your reaction. This is called S bar. So use this logic even in an exam. What is the situation? I am looking at a hypoxic patient in the ICU. What is the background? This patient is had an MI and had a percutaneous intervention. So your analysis is, I have a patient with a post-percutaneous intervention with hypoxia. So my reaction, my assessment is probably this is cardiogenic pulmonary edema. So what is your reaction? So structure your answers in that direction. You are most likely to be right and less likely to falter. Arindam?
Yep. Anything to avoid while putting up your framing up our answers? For example, I can give very to avoid trade names, for example, right? So rather than using trade names, we should use pharmacological names. As you said, very choosy words rather than saying normal saline or ringers or others. We can use generic, which encompasses everything, like balanced salt solution, balanced crystalloids. Yeah. So any tip on that?
Yeah. So as Arindam said, avoid brand names. For example, what antibiotic would you use for this patient? Don't say augmentin, right? Give the pharmacological composition of the drug that is being used, and don't give answers based on some single case report which you have studied yesterday. That will not be appreciated, right? So suppose there may be, there may be anecdotal evidence, there may be some rare manifestations, there may be some case report which you would have read somewhere, but that should not be or your own unit may be practicing it in some way, in a particular way. For example, I've gone to several exams where candidates have said PRVC is the best mode of ventilation because their unit uses PRVC as the default mode. But can you substantiate that answer with evidence? No, you can say that there is no evidence to say that a particular mode is superior to the other modes, but my unit preferentially uses PRVC mode for ventilation. You can use that, right? So what you want to convey should be backed by some strength, and that strength comes from either RCTs or published data or a guideline or a best practice statement.
I think what we can also deduce from what Srinivas had said, I think I will also include Vivek sir if he's there, that as we are going to our highest level of examination, right? We are in the postdoc state and all others. So there are no black or white answers, right? So there would be answers which are in between. So we try to analyze the candidates' ability to back up their answers in terms of either evidence and logicality. So Vivek sir, what do you think? That there are no clear answers at times, right? So we try to assess whether they can defend their answers with all the evidences, all the logical explanations on that part. What do you think?
Yeah, I think the first thing is if you are entering a gray zone, you have to have a very logical analysis that you have entered a gray zone. Then if you are entering a gray zone and you need to move from here, I think the first pearl will be safe practice. Do no harm. So amongst the options which are available to you, select what you feel is the most harmless. Now, in the most harmless, of course, you may not be having endorsement by one society guideline or two society guidelines. You may be having an endorsement by consensus, or you may be having a best practice statement. So I think when you enter a gray zone, be clear that you are in a gray zone. Do no harm. Pick out what are the safe options. And if you have to move in for a safe option, then look at the evidence, and the evidence will be it'll probably be at the most a best practice statement, nothing beyond that. If that is also not there, there'll be some consensus. If that is also not there, probably it will be the standard accepted practice, maybe in a particular unit or in a group of units, So I think the most important thing is do no harm when you are in a gray zone, and talk it out to the family, to the patient, and then take it ahead.
There is an interesting question from Jairam. That sometimes it is difficult to recollect some good words, and we end telling different less favorable word. What to do at that time? Srinivas, what to do at that time, right?
So at that time, don't tell the wrong word, right?
Yeah. Do no harm.
Yeah. So the best word.
Very good answer on that. Don't say the wrong word. Yeah. Even less favorable will do, sir, but not the wrong one. I think Dr. Srinivas got.
So I think they need to learn to speak if you are having rounds and if you are presenting cases and if you are trying to talk and discuss. I think that is the only way the right words will come out at the right time. If you have not presented cases, it will be like anomia, and then you will not know what to say. So I think if you are talking every day during rounds, and even if you don't want to talk during rounds, you are talking during handovers, I think it's a very good practice. So if you present your case once to the consultant in rounds, and if you are talking during handovers, and you are discussing the cases with the primary consultant, and you are taking the referrals and calling up the consultants to whom the case is referred, I see no reason why you should not land up with the right word at the right time. It's just a question of practice. It's there inside you. It just needs to come out.
Dr. Srinivas, you have rejoined? Yeah.
Yeah, I'm here. So my question is, you still have about 15 days to go for the exam. My suggestion to all of you who are now appearing for the practical exam is to make it a habit to present a hot case to your consultant every day from today till the day before your exam. To get into the habit of this SPAR thing, you know, I mean, when you do your routine handover during your day-to-day work, sometimes you just you use bed number or something like that, and then give a handover. But request your consultant and your guide to actually take you through at least one admission on the previous night, or one patient which nobody else has seen, or you have not seen. Go through the patient for an hour or so, and then present it the way you think you should be presenting it in the exam, and request them to question you through your decision making process. For the next 15 days, if you do that, it is like net practice before you actually start the actual game. You can see the ball, you can adjust the swing, you can adjust for the bounce, so you will play good innings.
I think this is what exactly the echoing the words of what Dr. Vivek said, that you should, whatever time you have left, you should present it and make it a practice. So whosoever is there, preferably it is to be, if there is a senior or one of the examiners in your unit, or otherwise your faculty, or even to your colleagues would do, right? And that will bring out the best out of you, the assertiveness, the confidence, and all others. But most importantly, forget about the things, the confidence, the steady voice, the modulation of your voice, the choosiest words, and not using a lot of jargons or trade names. If you make all those things, and if at times you have chosen something which is you shouldn't have, so you can come back and we will be apologetic. You see, as an
One thing I would like to, one advice I would like to give all the students is that at this stage in this exam, don't say that you got tense because of the exam. Don't say that you gave a wrong answer because you were nervous, because you are now going to be a consultant, right? You are now going to be a leader of your own. So the examiner would not like to hear from you that a probable team leader is actually panicking or is probably getting nervous when faced with a clinical situation. So while it may be acceptable in a postgraduate, undergraduate exam that a candidate is nervous, it is not appreciated, usually not appreciated in a DrNB exam. So don't take that route as a as a exit from your problems.
I think Dr. Vivek will agree with this statement, right? What we are expecting once these guys pass, only in a matter of 2-3 hours, they would be part of us. So we would need someone who is confident as safe as us. Your comments.
So Arindam, if you remember in 2008, when we met for the first time, when the EDIC team had come to Hinduja from UK, I think the first thing they said that what we assess in the candidates is that whether it is safe to leave the unit on them. So that's it. So if after his exam, if next day we can go on leave, leaving the entire unit to this guy. So I think that's what we are looking at. How safe are the patients when it is left with this candidate? I think that's the end point of examination. It does not need good, very high level of knowledge. It needs very sound knowledge, sound working skills, and a very mature and a balanced mind and a thought process. So I'll still stick to that doctor's statement. I'm forgetting his name. That how safe we feel if we leave our unit with this guy. I think that's it.
Sanjay was there. Some Bath. He was from Sanjay Kumar from Bath.
He was from KEM. I don't remember his name now. Yeah.
Yes. Sanjay Kumar from KEM and Bath. He was practicing there. And we learned that a guy who has passed is safe to manage without the senior consultant, and he is confident enough to tackle the major emergencies. Yeah. He is wise enough to tackle some non-clinical administrative issues also, and he can be safely given over the sickest of patients, and at least he will understand the problems, and in extreme cases he will seek for help. So this is what we are assessing from you. So before Vivek sir, you would be there, but I would take this opportunity as you are here and you are the first person to do the European diploma in echocardiography, and you have an immense knowledge on critical care ultrasound. So what are the things that they should very quickly brush up before going to the examination? Because there would be certain screenshots or videos included within the tables, and at times some basic things can be asked in a long case, short case, or any situations. So what should be the last minute brush up?
So the last minute brush up is no case at the bedside is complete without a point of care ultrasound. So if you have not done any, but you are solving the exam cases. So for every case, say you are starting with a case of SAH, immediately Google point of care ultrasound SAH, pick out 3 cardinal points. So at least you should know that if you do serial TCDs, you can pick up vasospasm earlier. And for vasospasm, the peak velocities will, the mean velocities will go up. And how do you differentiate the Lindegard ratio between vasospasm and generalized increase in flow? Something like that. So the moment then you come down, the moment you're looking at aortic dissection. So if you are reading aorta, or if you are reading acute aortic syndromes, which is a topic I love, because I got screwed on that for years. So if you are doing acute aortic syndrome for everything, for whether it's an intramural hematoma, whether it's an atheroma, whether it is type A, type B dissection, immediately Google and see the relevant images. And when you are seeing the relevant images, don't stick to transthoracic. So like for the descending aorta, it has to be a transesophageal. So you write point of care diagnostic images, and keep seeing the image. So with whatever you study, you see the image. One, it will increase your retention, and second, definitely it will help you in the exam. Now, whether it's a acute renal failure, you just write, pick up what is the renal resistive index. If it's any chronic organ failure with decompensation, so you should know, and it's floating on the net. So IVC waveform, the portal vein waveform, the hepatic vein waveform, what is the Vexus score? I mean, just keep seeing it. It'll take you exactly 3 to 4 minutes to see a video, and just pick out 3 cardinal points. So like we have done clinical, we have done monitors, we have done the labs, hematology, microbiology, blah, 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 imaging, and there you have a point of care ultrasound. So just add a point of care armamentarium to every case, whether it's necrotizing fasciitis, it's septic shock, it's acute pancreatitis, or it's any chronic organ failure, anything and everything in the engine. Suppose you are reading ICU acquired weakness, just write point of care ultrasound. So there are many people who are doing the muscle mass estimation by doing weekly ultrasounds on that. I think it just adds a new dimension, and since it's a visual dimension, it helps in the retention. Thanks.
I think that was a brilliant way that for all the important cases, be it a long case and short case, we should go back and look into the point of care diagnostic. What are the diagnostics that are available for that age? What are the, at least you look into the screenshots or the videos and have a basic idea how to perform them. At least the ideas to approach towards them. And I remember I had been fortunate enough to work with Vivek ji, and as he has been my senior colleague, and his rounds are always with the ultrasound machine itself, right? So whatever the clinically and investigation wise as well as discussion wise we were doing, by that time Dr. Vivek has performed a very quick POC test on the patient itself, and many of the times he would have found out something which has not been found out in the overall clinical examination or in the discussion part. So that is how his students and his colleagues have learned from him, that how quickly that can be picked up. So thank you for giving us that exposure on that part. Srinivas ji, before ending up your session, do you like to add something? Sir, you have to unmute, sir.
Summary of what the case scenario which you have examined for half an hour should be a very elegant and very concise summary of the clinical, the laboratory, radiological, and evidence-based information. So just as we said, talked about ultrasound. So if you are looking at, say, a pneumonia, for example, an ARDS patient, for example, your answer, your assessment of the situation should be the time duration of illness plus the current severity of the ARDS, the lung compliance of the patient, the radiological appearance, and evidence-based wise, what is plan A, plan B, plan C for that patient. So if you can put that all in a nutshell and be ready, I think most of you will sell.
Vivekji, any concluding notes?
No, I think the best way to learn and practice is to speak during rounds. Speak to all the consultants to whom the case has been referred. Don't be scared to call up the primary. Most of the primaries respond abnormally at night. Some respond abnormally in day. And if you definitely call up a consultant at night, please don't expect a normal response. But don't be scared. I think you can take it like a viva. One is to discuss your clinical knowledge base, but how also to master communication with difficult, I will not say relatives, but then difficult consultants will help you in handling difficult relatives. So if you are speaking and interacting, there will be mistakes. Obviously, if you don't interact, there will be no mistakes, but don't take stress, just do it and then push off. So I think if you are talking in the same words, you will find ultimately 80% of the treatment sheets of the intensive care unit are same. And most of the clinical issues are the same. One patient may be in septic shock, second may be in obstructive shock, third will be post-op. So it's the same thing which keeps rotating, it is just that which patient gets what. So I think after a month to 3 months in any unit, you should have mastered that particular unit and interact with all the technicians. The dialysis technician, or say abroad you have the CRRT technician, and then you have say a respiratory therapist, interact with them, the phlebotomist. You will come to know many fine tips which normally are things which you take for granted. So I think that's all. And even the drugs, whenever a drug comes, always take it. If it's a new drug, take out the package insert and keep it. I mean, in previous units, we used to keep it in a file. Otherwise, you can keep it with you. Read the package insert. Whenever a new drug comes into the unit, please read the package insert and, put it in a common folder, at least for 3 months till the drug has been used 4 or 5 times.
Okay. Thank you, sir. Thank you, Srinivasji, also for joining. And I would request both of you to join for tomorrow and day after tomorrow and take certain examinations of candidates. And for your information, that we would be parallelly conducting 10 examination halls. So in each hall, there would be one examiner and one examinee, and there would be certain number of candidates who would be also observing the examination for the others. And you would be given a preset questionnaire, cases and questionnaires, so that we can maintain a parity and uniformity in all the parallel examinations that would be going. So every long case, short case, and all others would be uniform and same to all the candidates itself. And you have to be very time bound. You have to finish it off within time and keep 1 or 2 minutes to give a very quick assessment of that individual candidate. You are not going to debrief the entire case, because debriefing would be done in a common platform. So what would happen is that 10 different halls, the examination would be ongoing. Once all the examination is done, we will again rejoin in a common meeting room, do the debriefing, and then again go back to the individual examination room. So a detailed...
There is a question in the chat box actually by Dr. Rajat Chaudhary, who's asking about whether cross consultation should be mentioned in the... Definitely yes. Now, for example, if there is a liver failure in a patient whom you are seeing, you should always say that your decisions will be taken in conjunction with the hepatologist and the transplant team. Similarly, if you have a patient with a bad subdural or a subarachnoid, you will always talk about making decisions and planning the treatment of the patient in association with the intervention neurologist or a neurosurgeon. For burns, a plastic surgeon. For postpartum hemorrhage, an obstetrician, an intervention radiologist. So it would be actually good quality of care and good assessment if you actually identify who are your supporting team for the successful management of it.
In fact, in every answer, there should be in the best interest of the patient. If it is beyond the capacity of our primary specialty, it is always imperative if patient family doesn't have to ask. It is, and by default, you have to take a opinion of a suitable specialty. So be it a neurosurgical in traumatic brain injury or a cardiothoracic in a suspected what Vivek has said as dissection or aneurysm. So that is by default because we manage the physiological upkeep, but certain definitive management are done by the relevant super specialty or subspecialty. Right. For example, a bleeding patient, an intervention radiologist opinion has to be sought if there could be prevented. So that goes without saying that the relevant super specialty or subspecialty has to be involved, and at times it's pro bono that we have to do it on that part. Vivek ji, any comment on this?
No, so I think nothing. I think I have nothing to add. Best wishes to all the candidates. And exam is just one day in a life, so you just have come there to walk through. If you have been working regularly with a little bit of daily studying, you cannot fail. But if you have not been working, not been presenting, not been talking, and only reading, the connection may not get through. It will say this number is busy, please dial again. So you have to be working. You have to be very active in your unit. Whenever you enter the unit, see the cases, talk to everybody, make your mistakes, open up your Washington's Manual of Critical Care, read the basic things there, and then go home, and whenever you have time, read the mother book. Always have a mother book with you. And then
what do you say about, like you, that the emotional quotient has to be pretty high for all the candidates and all the people?
Yeah, you have to be passionate about your subject. If you're not passionate about the subject, I mean, I think intensivists have many enemies in the hospital also. So you have to be very, very passionate about your subject and every day will be a new learning in the intensive care unit. There will be a new bug. There'll be a new complication. There'll be a new audit observation. So I think, and there will be one difficult relative and one difficult primary. So, these are parts of life. You have to learn to wade through them. And if you are dodging them, it will not work out. The moment you learn to handle with them, you will find that, somewhere or the other success follows.
Fair enough. So I would thank both of you. And then we move to the next part. I see Dr. Darshana has joined. Dr. Darshana. Thank you. Dr. Darshana, madam, I think you are not being audible, sort of.
Arindam, I'm still with the auditors. I just started.
Okay, so should I get you later on?
Yes.
Okay, fair enough. Okay, so just ping me whenever you are free, then I can include you in the discussion part.
Sure.
Okay, thank you. Thank you. Then I can also see Proloy is there. Proloy, are you available to have a discussion?
Yes, sir, I am available.
Okay, so Proloy, you are one of the very few, the first people. Hospital. So you are the first few people who have cleared the DM examination, and DrNB, we can say, is the equivalence of our the DM examination itself. So can you please share your bit of experience, how the exam was, and then I will ask you certain other questions too. So Proloy, I have to give you a name. Proloy is working as a consultant, a senior consultant in Tata Medical Center, Kolkata, and he has done his DM from SGPGI, Lucknow. Yeah, Proloy, please.
Thank you, sir, for this nice introduction. We were the third batch in our hospital clearing DM. Dr. Divatia was there for the final exam. Usually we have 2 long cases, and after that we have a series of tables which are taken means by the internal and external examiners together. So usually we get around 20 to 30 minutes for each case, and then the case presentation to the examiners is around almost same time, what Sad has already mentioned in previous sessions. And the important points are, so patient who is unconscious in coma, so we take the permission of the teachers so that we can include the relatives of the patient for the discussions of the history, regarding history and a bit of examination of the patients. And regarding the tables, we are having all sorts of graphics, drugs, and we have dialysis machine and ABGs, and everything is included there.
And you also had your dissertation and your logbook being analyzed, right?
Yes, sir. Yes, sir. And we were given one journal to assess, and we got almost 5 to 10 minutes for that.
So overall, and there were, what was the ratio of, I was intrigued, that number of examinees and number of examiners? Was it too intimidating?
No, it's fine. Means so I had 3 examiners, including Dr. Baronia sitting on the opposite side, and Dr. Divatia. It was they were always encouraging for the so.
And how many examinees were there?
We had 2, me and Dr. Sai sir.
So it is always 3:2, right?
Yes, around like
most of the time in this sort of postdoctoral examination, the numbers would be always close to 1:1. If not, you have more examiners than the examining.
Yes.
So that is a little bit of, not a point of worry, but a point to be noted, that there would be more examiners at time than the candidates, number of candidates. So that is an Pralay, tell me that you had been through this experience, right? You are an excellent candidate, excellent teachers, and a student initially, and now a very, very good teacher. So these guys do have 2 to 3 weeks time left, right? So, and including the Diwali to enjoy, right? So what would be your tip for last minute preparation?
So I will suggest that they should continue their case presentation with their fellow colleagues with whom he or she has done DNB together, because those persons are most concerned for their exam. So they should present their cases, means it should not only include the cases in their present ICU, because most of them are they have left their previous institute and have joined a new institute, and they have a specific type of patients. So they should make a list of all cases which can be there in their exam, and they should continue the presentation over phone probably, and they should find out one student or somebody with whom they are giving round to discuss those cases. Regarding the tables and graphics are concerned, I will suggest them to make a list and collect all the resources so that they can go through quickly, and they can cover each topic. So means they will stay most of their time at the bedside, so they should utilize their bedside time. Sir,
any specific thing to read or something of that they haven't read or something as a last minute?
Means if they have not included anything specific pertaining to the tables, they should include those things. Somebody has mentioned PFT, that is an important topic. So I think they should make a chart of make a list which can be included in the tables, and they should read everything about that. Nothing specific.
Normally PFTs are not in the, I have not seen regularly being given. It could be in your long case, short case, but it would be very basic that you already know. But curves and loops, particularly the loops, PV loops and all others, those could be there. Not very detailing of the PFT, and which is not pertaining to the acute situation would be there. So no need to worry about it. We will discuss about the list of the things that could be included into the table itself. Pralay, anything about that, the different journals in the last 2 to 5 years? Anything you want to give a list of it? You can take your time and come back on that part also.
Yeah, definitely.
I would request you that if you can do this part for us, that if you can give a list of 10, 15 articles that should be read before going to the, which are important in last 2-3 years time, which should be read in before going to exams, at least in the abstract form. So if you can do that for us.
Yeah, I'll do that. I'll share with you, sir.
Okay. Now you don't have to share with me. I will. You can come back in a while and tell that on that part. Anything else you want to add, Pralay?
No, nothing. I just want to mention that you have to practice and practice. That's much.
So practice whosoever you get, whosoever withstands your onslaught.
It may be maybe technician, maybe nursing staff. They should present.
Whosoever endures that pain, you just get them and teach them, and in that process you improve your skills of assertiveness, your skills of expressions, your skill of reaching out to people. So that is the most important aspect, the practice and saying. You see, I was one of the most shy guy in my school and college days, and only by practice, by attending, by committing mistakes and all others, I hope I have improved a bit. And I come from a vernacular medium also. So the fluency, the choices of words, the expressions, the voice modulation, everything is being very, very important on that part. So thank you, Pralay. I would ask you can take a leave, but we would be very grateful if you can come back after at the end of the program and give us a little bit of list of at least around 15 papers that should be known by the candidates before going to the exams.
Sure. Thank you, sir.
Okay. Thank you, Prabhat, on that one. I think Dr. Gunjan has joined. Dr. Gunjan, are you there?
Yes, I'm here.
Okay. Gunjan ji, I think they are orange bar. I'm eating like anything. Diwali, happy Diwali. Gunjan ji, so a very important aspect that what should be known by the candidates, which the topics which can be included into the tables and OSCEs, if OSCEs are there. So if you can very quickly give a brief of that.
So tables can be very extensive. They can be like, they already have division of tables, but where we usually find a difficulty is not in mainly procedures or hemodynamics or the ventilator. The main difficulty is when we see in ventilators, usually it is the asynchrony part, and otherwise the biochemistry part or interpretation of data usually. But again, the questions that we get from the interpretation of data are not very extensive in critical care, honestly. We need to know our electrolytes and endocrine system very well, the nephro, endocrine, and the electrolyte systems. And that usually covers up most of the data interpretation section.
So if I say so, one by one, if you can guide me, you have said that in the ventilation, mostly asynchrony, which is little difficult at times to find out, and then certain values and some certain procedures, right? And maybe some loops and others.
Because procedures people have been doing for 2-3 years, that they have the DNB section, they are definitely doing the procedures since 3 years. So that,
okay,
I don't think procedures is much to worry. The main issue in worrying is when they have data interpretation. Data interpretation, again, in imaging, most of the people, if they have practiced echo and seen a lot of CT, MRI, they have been regularly seeing them, then it's not a huge task. But if you're not interpreting them on a daily basis, that you're depending just on the report and not looking at the images, then it becomes difficult on the last week or the last month. The data interpretation becomes difficult. But again, as I said, I have listed a few things which I thought I should share, which in data interpretation. So like knowing your electrolyte interpretation, especially for the sodium, what is SI?
Do you want to share? Do you want to share something in a
slide? I don't have a slide. I just wrote down a few.
Okay, so you can note down, please. People can note down this, what Gunjan is saying. So can you go system by system or segment by segment? For example, in ventilator graphics, in hemodynamics, in cardiovascular support, in CT, something of that sort. Can you give a little bit of clue on that?
I will quickly share then if you want. The data interpretation, I don't have much to share. But in CT and X-ray, I have a few things to share. Maybe I'll quickly show you all.
Okay, that would be great.
But then I will, maybe just the answers is what we can see.
Or you can just enumerate.
Okay, I will enumerate.
The candidates will take a note of it.
Okay. So in X-rays, usually if you see the X-rays, we can get a cervical spine X-ray, a chest X-ray, or maybe a pelvic and a bilateral hip X-ray. There is no other usually X-ray which comes. In cervical spine X-ray, there could be anything with a fracture dislocation of the cervical spine or anterior displacement, retro displacement, retrolisthesis. These are the common ones. And all they have to see is the lines that they commonly are seen. Again, bilateral pubic X-rays, pelvic and the bilateral hip X-rays that are there, you may find rami fractures, open book fracture, fracture of the femur, intertrochanteric, and sometimes they may give you a gas gangrene with a limb which shows some gas in the subcutaneous tissue. Then in the chest X-ray, it could rate, if you look at the lung shadows, then the lung shadow can have everything like from a collapse, effusion, pneumonia, which you have to always give a differential. You cannot give a single point that this is a lobar pneumonia. You should always ideally give a differential. You may have a pneumothorax or a massive pleural effusion with a shift to the respective sides, crescent signs, ARDS, miliary Cox, and presence of certain devices. You may have to look for right position of the PA catheter, central line, endotracheal tube, or even a nasogastric tube, which may be dislocated. And then what else can we have? We can have air under the diaphragm. When you look at, they may show you a chest X-ray, but there may be a air under the diaphragm. Sometimes there may be superior mediastinal widening, pneumomediastinum, and there could also be diaphragmatic hernia with the organs in the chest. So these are the basic X-rays which are there. And, devices, again, as I said, you may even sometimes see a pacemaker device. And in the abdominal X-ray, intestinal obstruction or a Ogilvie syndrome are the common X-rays that come. Okay. When we come to CT scan, again, CT scan, very limited information is asked. Mainly for the CT brain, we have infarcts, which are, or we have bleed, which is SDH, EDH, intracerebral bleed, subarachnoid hemorrhage, hydrocephalus with intraventricular bleeding. Then you may have venous infarcts. Usually, this MCA sign may be there. Hyperdense MCA sign may be one of the important scan which may be seen. SOLs are very less asked, but still you may have an idea that enhancement post contrast enhancement of a SOL may be shown. Then when we come to chest CT scan, again, trauma is extensively covered here. There could be ARDS, emphysemas, pneumothorax, pulmonary embolism as one of the contrast CT scans of the chest. Then aneurysms of the aorta, descending aorta or ascending aorta, whichever. Then abdominal CT again has only probably 2 or 3. Mainly, you would have a trauma with a ruptured liver or a spleen, or a emphysematous pancreatitis, or a pyelonephritis. Usually, these are the important ones. You can also have sometimes acalculous cholecystitis or even a emphysematous cholecystitis. So these are the common CT scans which are there. MRI usually only the brain is asked, wherein the infarctions are seen, or so they may show you a diffusion weighted, a flare image. So reading the types of MRI images that you have is very important. And you may sometimes they may show you swan images where there may be bleeds, and very rarely they may give you an MR angiography which shows 1 or 2 aneurysms occasionally an aneurysm. So just looking at the circle of Willis will help. So use of FLAIR for the thrombolysis decision, or the diffusion for the thrombolysis decision is what can be one of the questions which can come in the imaging section as well. So these are mainly which are covered in the imaging. When we come to the biochemistry tests, then if you go from system wise, the tests which they give, the values, numbers rather, which I would say, they can give you ABGs, which are very common. If you look at the respiratory system, they may sometimes give you ABGs which go indicate towards brain death. So neuro may usually they can give you only that. Then toxicological, they can give you many numbers with maybe a paracetamol poisoning or ethynyl glycol, methanol poisonings, and or they can give you electrolyte imbalances with which SIADH, cerebral salt wasting. Then other common ones are tumor lysis syndrome, refeeding syndrome. In the hemat part, they may rarely give you multiple myeloma or a TTP kind of a picture. And sometimes endocrine with a cortisol deficiency can be given. So these are the common data interpretation questions which can come. And what else can be there in the table viva is they can ask you procedures, obviously complications related to procedures. They can ask you ACLS, ATLS protocols. Airway again is very extensive, and knowing about your difficult airway is again an important thing. When we look at the ventilator graphics, most of the graphics are mainly about the leaks, about air trapping. Then asynchrony graphics are a little difficult, which you need to see, because often we see an interpretation we do on a daily basis. But usually asynchrony or patient ventilator dysynchrony graphics is what usually confuses me also. But I think we should all make a habit of seeing them. Then hemodynamic monitoring, we can have cardiac tamponade commonly. You can have VSDs, or you can have maybe a junctional rhythm. All those things can be there. ECG is again an extensive topic to be covered in a table viva. Or even ECMO nowadays, IABP traces early deflation, late deflation, early inflation, late inflation. Very common ones are usually seen. And drugs can be anything from anesthetics that we use to cardiovascular inotropic supports, to IV fluids, albumin, or even antibiotics. So drugs is an extensive topic again, which needs to be read. So these are basic about table viva that needs to be covered. Any other inputs you think I must have missed?
Any of the other graphics or screenshots, like some CRRT or the ECMO machines or tags or something of that sort? Yeah.
Tag, do they ask in DNB now? Tag, and in EDIC definitely they are asking tag and ROTEM also, but I'm not sure about.
I think that can be included into the long case if there are so, because yes, you see, we cannot claim that's a problem. This is the culmination of whatever we have studied all through our life. This is the highest level of exit exams that one can give in their career. After this, it's more of a fellowship or something of that sort. So I personally think that there is no limit. Anything and everything in a DM or DrNB exit examination can be asked.
Absolutely.
Right? We can go even up to the philosophy also. Right. So that's the part. You cannot say this was not in the syllabus. Right. Everything can be tested. So I think it's better to be prepared for a tag. And
EEG and ICP traces is what they should read about.
And there won't be much of an A, right? We should know to come up with a isoelectric or no signals or some spikes, or right, maybe metabolic, the typical EEG features of metabolic encephalopathy and all others. TAG is also not very much, only 4 or 5 different types of TAG.
Yes.
And basic interpretation of the.
Hardly take them 30 minutes to master the TAG, ROTEM, EEG, and ICP.
Right. I think that should be your A. So in last 4 or 5 days, you can quickly sum it up and all others.
4 or 5 days.
And now everything put together, whatever you said, right? So if you can come up with everything, right? All the pictures, all the ultrasounds, echo videos, as also Dr. Vivek said, that every every important disease process, if you see what is the POC finding on that, right? That will include everything. And also CT scan. I was wondering that MRI, right? MRI is a little difficult part. Many of the times our physicians, even radiologists, are not very sure about the MRI. There are controversies on interpretation of the MRI. So what would be your suggestion? What MRI should be the bare minimum our candidate should know?
So MRI, they need to basically know what type of, what is T1, what is T2, what is diffusion, and what is flare. Once they understand the basics, I'm sure it is not very difficult to interpret a brain MRI.
Okay, so I think in that day, T1, T2, flare sequence and all others, have an idea on the sequence. Very quickly, don't waste much of a time. No need to be a neuroradiologist or something of that sort. And if it is ever given, or if it is included in your cases, right, it won't be then the stroke and sort of some sort of hypoxic ischemic injuries or something of the myelonosis, cerebral or extra pontine myelonosis, hypoxic ischemic injury, early forms of stroke, and anything that is important, and maybe a little bit of bigger tumors with vasogenic edema or something of that sort. So these are your standard, and some white matter changes which could be in a differential like infective and non-others. So I don't think that there should be any important MRI beyond this, which is required to be known by an intensivist. The rest of the things should not be included in the examination itself. But I think CT, yes, please.
Very true, sir. MRI very selective are there.
Yeah. But regarding CT, you should be a little aware of. But normally, remember, a good examiner or a center, good center, will try to restrict itself to the subjects and situations which are specific to the critical care itself. It's not a medicine or pulmonology or a neurology examination, right? We are not here to find out that what is your skill on interpretation of difficult or very, very uncommon. Rather, we are here to find out whether you are being able to detect a life-threatening situation very quickly, and rather you are more appropriately taking the intervention to save life. So that's the aim. Okay. Okay, it's a question from Gunjan yourself. When in the exam?
I have no idea when the exam is. I'm asking.
I think somewhere between 11th to 20th. That is the best bet as of now. That is the information that we have got. So I think we got around 2 to 3 weeks of time itself.
Okay.
Any question from the candidates? You had been
they also have
very quiet.
eco and USGs?
Yes, there would be.
Okay.
There should be.
So that is
once
again,
we get a little bit of idea from the national board, then we would be picking up on that part. Okay, so I would, if there are no questions from the candidates, then I think I can ask Dr. Gunjan to take a leave, because she has got a huge responsibility also. Me and herself and me rather, I'm putting her first. We are making up the long cases and short cases. So I would ask Dr. Gunjan to concentrate on that, and she can take a leave if she wants to. So thank you, Dr. Gunjan, for all your effort. It wouldn't have happened without you. You are the main person behind it, and thanks for your relentless effort to do that. And I thank you also on the behalf of all the candidates.
Thank you so much.
Thank you. And I think we have many of the people. Now I can, before other people also do join, and Dr. Darshana also gets free, I will take up certain questions. Dr. Panja has joined. Dr. Panja, sir, if you are there. Sudeshna, can you ask Dr. Panja to, if he's somewhere around? Dr. Anirban, he has also joined, it seems to be so. Dr. Anirban?
Yes, I have joined.
Okay, sir. That's now the star has come. So Anirban sir is our very, very good friend. Okay, regarding
Yes.
I think Dr. Anirban Om Chaudhary, everyone knows him. He is now the professor and director of critical care in GB Pant Hospital, New Delhi, and he is one of the most, what would I say, multifaceted talent in critical care, be it academics, be it artistry, be it singing, music, everything, film direction, everything is there. But more so, in context of our today's program, he is one of the person who is involved in the exam process, setting up the syllabi, laying down the guidances and principles, recognizing institutes for DM and DRNB. So he is everywhere, omnipresent. So you won't get a better and experienced person in terms of examination and process setup than Dr. Anirban himself. So Dr. Anirban, very quickly, the first question to you is the statistics that they should know. What should be the level and what are the basic minimum they should know? And what could be the last minute brush up for them?
Arindam, you have started with the most difficult bouncer on the first delivery. And because statistics is something that all of us, we are learning. And in course of time, we have learned little bit, but more we learn, we realize how much we don't know. So to summarize in short, statistics is necessary. Earlier, it was not considered, it was considered as not so important, and somebody considered that if they can name a few tests and terms, they can hoodwink the examiner into believing that they know a lot of things. Now, that is not possible nowadays. So before statistics, two things are very important because that goes by the guidelines of NMC also, and it holds true for National Board also, that everyone should undertake the research methodology course within the first year of enrollment, and the thesis should be submitted before 6 months of the theory and the practical exams. So these two. Now, besides the research methodology, two more courses which are also mandatory for everyone. One is the GCP, that is the good clinical practice or the good laboratory practice, as the case may be. And the third is the ACLS BLS. So of course, ACLS BLS is nothing new. Most of the candidates are adept with that and they have their certificates. In statistics, you have to know what number one is, how to calculate the sample size. Many of the candidates will be doing their dissertations and they will be calculate the sample size. And if they may be asked during the Viva or any time during or after the exams or in any context that how did you calculate the sample size? So calculation of the sample size is variable. It varies from whether on the study pattern, or depending upon whether it is an observational study, whether it is a randomized control trial. So everyone should know how to calculate the sample size, that what are the things that a clinician needs to tell the statistician for the statistician to calculate the sample size. So understanding the principles of sample size calculation, like if the incidence is too common, then probably a lesser number of sample may suffice. If the problem is a very rare problem, then the sample size may be big. So these are the effect size of any particular research methodology that has to be understood. So if one undertakes that research methodology thoroughly in the first year as mandated as per the NMC curriculum, then one will be able to get a good grip of the sample size. Next important thing to understand is the design of a study, that how to design an observational study, how to design a clinical trial. These two should suffice. Observational again has case control cohort. So it all depends on how to design a study. The design pattern has to be known. The third thing is understanding the type 1 and type 2 error. What do we mean by type 1 error? What is p-value? What is confidence interval? These are some of the things which everyone should know. And then, of course, a few basic statistical tests like the student t-test, chi-square test, Mann-Whitney, Wilcoxon rank sum. So these are 4 or 5 tests if they know. So I think that should suffice the purpose for the exam.
Okay, so not about the regression analysis or any
Regression
other.
and correlation are
Yes.
considered to be slightly above in the next stage in order of importance. So if they understand the basics first, then without understanding the basic statistical tests, it will be a little bit difficult for anybody. But if they can do it, then it is of course very good. The correlation and regression, including the logistic regression and the multiple logic regression. But before that, at least students t-test, chi-square test, when the groups are more than 2, when comparing categorical against categorical versus quantitative, quantitative versus quantitative. So how this nature of the test changes, what is normal distribution, if it is that if they are in abnormal distribution, how to do the logarithmic transformation to convert an abnormal distribution, non-normal distribution into normal distribution. These are some of the basic things that are more important. And of course, in research methodology, the ethics part and the processes of randomization in clinical trials, what are the sources of bias in observational study. These are some things which are expected from the candidates at greater length, particularly since this is a super specialty course.
So the next part I would be asking you, Anirban, is that there would be communication and your medical, legal and ethical aspects of care. And most likely it was being very clearly told by Bhuvna that there are directives that there should be separate tables or for the communications, right? And if for all practicality, we have seen in fellowship and DM examinations that there are actors who actually enact as relatives or any other suitable characters, and there are given communication scenarios are given, right? So what are the different aspects of communication scenarios that can be included in the examination, and how to prepare for that? What are the basic rules of communications?
See, Arindam, as far as my practical experience as an examiner goes, I didn't see students faltering in the communication part. Communication is more or less a subjective way of judging, and most of the students are adept to understand the means of what does good communication means, and more so during whatever they will be doing in reality. But during examination, they are all very communicating in very nicely terms with all sympathies and all possible in fine mood.
Sympathy, yeah.
So in exam purpose, communication may not be a difficult section to get good, fail to get good marks. But it is important that when we communication, there are several aspects of the communication. End of life is only one aspect of the communication. There are a lot of other aspects besides the end of life. That includes the informed consent and how much the patient understands before communicating his consent for any particular procedure or any particular remedial means which are trying to impose upon the patient or attempting upon the patient. So that is one. Another is the interdisciplinary communication. That is the communication between the physician or the intensivist and the paramedical persons, communication between the physician and the non-intensive care physicians. So these are also important ends of communications, and I'm sure that in the coming days when communication has been taken a bigger aspect, so these aspects will also be simulated, and some examiner may, instead of becoming a patient, may behave like a surgeon, and in that case your communication should be in a different note altogether from the patient. So all aspects of communication to prevent interspeciality conflict, patient-physician conflict, and they should be the candidates should be prepared. And see, Arindam, these are more or less, they are self-learned rather than being taught by the by the teacher.
Okay. So can I say in terms of communication, the situations can come as either as the end of life, where we can have medical futility, withdrawal of care, withholding of support or something of that sort. At times, there would be situations where brain death and organ donations issues can come up. There could be communication stations, because I'm talking in terms of the exam process, as this is a preparatory course. So breaking bad news, right? So informing someone about an unexpected thing that had happened. Admitting certain iatrogenic complication and sort of acknowledging that, how to follow up on that part. As you rightly said, informed consent, how to take a consent about certain advanced procedure, for example, putting up on an ECMO and something of that sort, right? Interdisciplinary communication, briefing someone about a sort of complex patient for referral and all others. That is also at times, right? Any conflict management and communicating about acute situation, which we can follow an S-bar communication strategy on that part. I think this is an exhaustive list. Anything you need to add?
No, you have said more than what it is there. This is enough. Or else
I think this
communication examination will continue for the whole day.
That would be. Anything on the ethical and medical legal issues they should be aware of?
Ethical and medical legal issue, a part of it they should be aware of. Number one is that how does this concept of ethics crept into critical care, the Helsinki Declaration up to. So this is particularly important in the context of research. So when they do the GCP, good clinical practice, a lot of perspectives
Nuremberg, Helsinki, yeah.
Of GCP involves around the ethical conflicts, the ethical which arises during research. So that is the primary part. Number two is that what are the basic principles of ethics? So autonomy, beneficence, non-maleficence,
and distributive justice. Yeah.
So along with on each of those parameters, how things can swell. That is, and initially when a patient is admitted in the ICU, in that certain beneficence may be more important, but in a later stage, non-maleficence may be important. In the last stage, if it comes to organ donation, justice may be more important. And so likewise, the importance of each of these pillars may change in the same patient over a course of time during his stay in the ICU. Now, if one understands the subject, the ethical concerns during in this context, one will not miss the primary importance of each of those pillars. And this will be a good way to deal with the ethics. And of course, one has to learn some of the cases as examples, like the guidelines which came in that pharmacology, this anaphylaxis case of Shukumar Mukherjee. So a few instances can be ready-made handy, and if they can remember it, it is fine.
So I can summarize from taking cue from your what you have said, is that basics, principles of medical ethics, and very landmark judgment or decision making like Helsinki, Nuremberg, and others, which laid down the principles of medical ethics. Just a basic fair idea, right? Including the GCP, Organ Donation and Transplantation Act, right? Because and how our just a fair idea how the system of Roto, Soto, and ZTCC has been revolutionized the organ transplantation system, and little bit of outlines of idea of organ transplantation itself. Advanced directives, which is in India, which is not very common, but we should know about the developed countries' advanced directive, living will and all others.
We are lacking in it at this moment, so we will have
but
to.
you are taking an initiative to do that. Then in case of situations where there are no, because now we are living with nuclear families, that substituted judgment, next of kin, doctrine of best interest, a little bit of 1-2 line idea of all these things.
Absolutely.
Right. And lastly, some certain landmark medico-legal cases that actually reshaped the way we are looking into the current medical practice, particularly the critical care practice.
Absolutely.
Fair
One
enough.
thing you have missed out, probably the logbook part you had written against me. I think that is also needs to be understand.
Yes, please.
That they have
logbook
to.
we have discussed earlier before we joined, but we would love to learn from you, sir.
No, then it's fine. I won't take much of time. But see, logbook, it is a verified.
Sir, there is enough time you take as long as you want to.
No, I'm not for that. Not for that. Since you have discussed already, there should not be repetition. I don't know what.
No, repetition. We have just given a little bit of idea on that, but we would love to listen from you. So don't restrict yourself.
So in logbook, since it is a verified record of a candidate's acquisition of knowledge, skill, competence, attitude, etc. The first important thing, it should be, the timeline should follow. It should not go in terms of alphabetically or system wise.
I will just interrupt you. Candidates, please note the word of a person who is so apt in medical legal. We have described logbook in many different ways, wherein Anirban described a verified record of your acquisition of certain things, right? So you can understand how well a person has thought of in that sense. And you need to look your logbook into that way. If you have not done it, you should teach your juniors to do that, that this is a verified record of whatever you have done in last 3 years. And I really thank you to describe it in such way. Thank you. Please continue.
So what I want to continue, I was remembering is, so when you write the logbook, you first make the objective whenever you're writing. So your objective may be securing vascular access. Then after objective comes activity. For example, like central venous cannulation or internal jugular vein cannulation. So after that, you write your procedure date-wise, get it signed by your senior, and also get it remarked, that is meets expectation or below expectation or exceeds expectation, and also the feedbacks. So and followed. So if that goes on serially, then that becomes a proper logbook. Then that's what the examiners are going to look for eventually. If not this year, over in course of time, this is going to the pattern which everyone would follow. Because if you go the same procedure repeatedly over a period of say in an interval of 2 months, 3 months, whatever time frame, it marks, actually it shows the way you have improved, or the way, or up beyond a portion it has not improved. So feedbacks are very important. So don't leave those columns blank, and don't follow the age-old habit of filling up everything in the last moment and getting it signed, because everyone can understand that. So make it a habit of writing it on a day-to-day basis. And also note that it does not mean that you are only writing your procedures. Even your seminars, symposium, presentations, the soft skills that you are acquiring, that is also a record of your logbook. And the counseling sessions and that you are undertaking with the patients, the difficulties you are facing. And so everything comes into the logbook. So logbook, in a way, without asking you, the examiner, with reading just by going through flipping through the pages of logbook, should be able to understand what are the methods, or what are the skills you have acquired, what is the attitude you have developed, etc. So I think it would be a good habit for you to start writing the logbook from day one. And of course, protocol you submit within 1 year. Start the study after the end of 1 year, after you have finished your research methodology and GCP training. Before that, you cannot start. And all your ethics, clearance, etc., the pages, you should take a printout of it and fix it before, like the way you do in every thesis. So these are some of the guidelines you should carry, and note that logbook will probably become more important than your dissertation in the coming times. I have this much only. Thank you, Arindam.
And I would request you, Anirban, to be as an examiner in coming 2 days. And we would send you all the cases and the questionnaires also. And you have to take individual one-on-one examination, and we will have a common debriefing. But at the end of examination, you can you should give a little bit of feedback of the candidate's performance and encourage them to do better in the actual examination. So see you tomorrow, and thank you for being here and encouraging the candidates itself.
Thank you, Arindam. There is one last question that I found in the chat box about the logbook. It is online.
Please.
So, online logbook is very fine. It doesn't matter whether it is online or offline. Online is probably better documented because you cannot fudge with the dates and other records. So ultimately the structure remains the same, that it should go by for anything that you describe in your logbook, the objective, the activity, the performance, the rating, and the feedback. The columns would remain the same, whether it is online or whether it is offline.
Yep. And I can agree on that part. And it is a good initiative by NB. We have had this discussion long back that should be online and dynamic, so that it becomes that you cannot go at the last 1 month or 1 week. You cannot put in data that you have done that. It has to be dynamic and what would you say, contemporary, that whatever you are doing today is being put into an NA. And time will come which would be they would be interconnected with the blockchain facility, where whatever you are doing, that would be directly uploaded into your
cloud
net-based logbook, notebook center. The NB has considered that also. Maybe in a 5-10 years time, that would be something of that sort. Even the RFID technology will revolutionize the tracking of the training that people would be getting. So we'll discuss about that later on in a different platform. Anirban is always interested to do that. And thank you, Anirban, for
thank you
for being here.
Best wishes to everyone. Good night.
Okay. Good night. Okay, so 3.5 hours. We still have certain points to cover. Let me see who is on board. I can see Kapil. I can see yes, Vaishali madam. Hi. So I can see Vaishali ji. So one of the most prolific speakers and most dynamic personality in critical care, Vaishali madam, who is an excellent intensivist, as well as she practices into the hepatology intensive care along with liver transplantation, but she has got a 360 view on critical care itself. And I welcome her, and she can start with some encouraging words for the candidates itself, and then I will ask her certain questions on that part. Vaishali ji, please. I think you have to unmute, madam.
I'm sorry for that.
Yes.
So good evening, everyone. So I'm going to take 10 minutes to talk about the topic, and that is better ways of communication. So communication is multi-pronged in the intensive care unit. The communication is between the intensivist and the family, communication between the intensivist and the multiple other faculties that are involved in the care of the patient. And the third, also important, equally important part is communication between the intensivist and the rest of the team, that is the junior doctors, the nurses. So really, the networking skills of the intensivists have to be at the peak to be successful in achieving the results that you want to achieve. And during the training time, it is best to observe the successful ones as to how they are operating on all these three fronts, that is communication with the relatives, with their colleagues, and with their own team. Because it's not easy. It is not taught in medical schools. Neither is it taught in your curriculum. It is something which is you acquire by observing your seniors and finding out what is the best and the most successful way. So, intensive care, as any other branch of medicine, is science, and there is a lot of art around the science. So science you will get a hold of much earlier in life. The art will take time. It's a continuous process, and believe me, I'm still learning 20 years down the line in the art department. Of course, the science also you continue to improve, learn, but the art is something which, there's a scope of improvement no matter at what stage you may be. So let me take up first the communication with the relatives and the family. So after a certain stage, when you have a decent hold over the subject, you would realize that managing the patient is the easier part, but handling the family and the relatives is something which you will find challenging, not only intellectually but also emotionally, because one does over a period, if the patient is in the ICU for 8 days, 10 days, 2 weeks, you become a part of what the family is going through, and it takes an emotional toll on you, depending upon how the family is affected by it. You also get affected, and you also become a part of their story. So it takes time to be objective and not get involved. So there should be empathy, and there should be tremendous empathy in all the communications. But mind you, you should not err on the side of sympathy or pity, because your decision-making will go wrong. So it always should be empathy. All your communications should convey empathy, that yes, you understand what the family is going through, and that you are doing your best. You, your team of doctors and nurses are doing your best. The other thing is transparency. So what happens in intensive care units, especially if you are in an open ICU, is that there will be multiple consultants involved in the patient care. And it is quite possible that they come at a different timelines, and each one is talking to the relatives. And yes, ultimately, the intensivist is also talking to the relatives. So the ideal method, which now almost all ICUs follow, is that to have a common meeting. All consultants involved, along with the intensivist, sit down and have a common counseling, which is not every day possible. So in such scenarios, you must be on board with what your colleagues have stated. Never be in a situation where you are either contradicting or you have made a contradictory statement, because that is where all the mistrust and the misfaith will start creeping in. So keep talking to your colleagues. Ask, be aware of what they have been counseling, and see to it that a common message is delivered by every consultant involved, because discrepancy will lead to lack of faith, and that's a disaster. That's once they start developing misfaith or lack of faith, that's a short beginning of a disaster. Also, it is better to maintain transparency. So, in the olden days, I remember, when I did my MD, relatives and patients, not patients, but the relatives would want you to give positive outlooks. They would, and a lot of practitioners would concentrate on the positive outlook. It is better to give a very factual outlook based on science, especially in intensive care, where we know that we have established data: 1 organ failure, what is the expected mortality; 4 organ failure, what is the expected mortality. And so it's better to sum up your assessment of the prognosis based on hard data, And sometimes if it is difficult because the disease is evolving and it hasn't reached its peak intensity, it is better to accept that it is not possible to prognosticate. So when you're yourself in doubt, you can just accept that, no, at this stage, I don't have enough information about the disease process to be able to prognosticate. And that way, it leaves the door open for any further counseling in case the patient deteriorates, right? So accepting that there are limitations to how much you can predict and prognosticate is the first step to having a transparent and honest communication. Now, the third thing is language. What language are you counseling? We live in a multicultural society now, and patients come with belonging to different backgrounds. And sometimes when you're sitting in the family meeting, you would realize that when you're talking in a particular language, sometimes you can see a blank look on the relatives, not because they can't understand, but probably because too much information overload for them. And so one has to judge the ability of the relatives to be able to absorb the information, and based on that, alter the speed at which you give them information. And sometimes you might have to alter that and sort of lay it down a bit gently, just so that the family doesn't panic. So that is about communication, and always document the communication. Most of the units now have audio-visual communication, so recordings of the communication are done, and the recordings and the video recordings are kept in records. It's the best way in today's atmosphere. There is no doubt about it, and many points which you may miss in putting it in black and white will be captured if you're doing a video recording. And without doubt, if the patient is very critical, and usually young patients where adverse outcome is going to be a bit difficult for the family to handle, I would advise that best to have communication with the family under audiovisual recording. Communication with colleagues. Intensive care is core and central in the ICU, and one needs to be in communication with all the faculties involved. And there will be disagreements, but it's the job of the intensivist to find the common pathway and get everyone to agree on the common pathway to take and agree on the common treatment for the patient, and then convey the common language to the relatives. It can be a bit difficult, especially in open ICUs, but this generation, I think by the time you are full-time intensivists and full-time consultants, I think many of you or majority of you would be handling a closed ICU. I hope so. And so that would become a much more easier job as compared to an open ICU. But even if you're in an open ICU, there is no limitation. There should be mutual respect and trust between all the colleagues and all the branches working, so that all of them are on the same page as far as the patient management is concerned. The communication with the team, extremely crucial when on the rounds. So when you decide the plan for the day, everyone should be on board. The doctors, the junior doctors who are on the round should understand what is your assessment, what is the plan for the day, and what are the steps to be taken. And the nurses also, the bedside nurse must be on board with your plan. If she has any concerns, you need to ask her. And sometimes they come up with points which you have ignored on your rounds. So because ultimately they are with the patients much more constantly than we are, and they observe much more. So it's always very, very helpful to take their feedbacks. At the end of your round of that patient, just ask the nurse, hello, do you have any concerns about the patient? Have you noticed anything that you need to bring to my notice? So always maintain good relationships with your nurses. I'm telling you, they will save you a lot of grief. Because they are with the patient, they observe small things, and their observations can make a huge difference in in the management sometimes. So handovers. Now this is this is an area where there is, no matter how many years you keep going on, handovers is an area with the biggest room for improvement. And handovers should not be taken lightly, right? Loss of information on handovers means scope for errors, scope for miscommunication by the next person on duty, and every effort should be made to minimize these loss of information in handovers. So extremely detailed handover, and every time, it may be repetitive, but every time starting with the background of the patient, the current diagnosis, the course in the hospital so far, and then the course throughout the day and all the events of the day, and what is the plan for the night or even for the next day morning or whatever the earlier person has observed. So handovers are extremely important, and having a detailed handover cuts down the scope of loss of information and cuts down the scope of further errors by the next person on duty. Because when you go on duty, even you would like a proper detailed handover. So that is what I would. Now the other part of the communication, I was hoping that Dr. Prashant Borade, if he's online, would take would be. Is he there, Arindam?
Has excused himself, so because of certain emergency, so sure. I can give a proxy, madam, if you ask me questions.
So, yes. So what I want to ask you is, I've always been on the receiving sides of transplantation. The biggest confusion, I must say, or not confusion, but the biggest area where intensivists need to be trained more and more is when you start counseling about organ donation and communication regarding organ donation. And I must say, Prashant I've seen him personally. He's absolutely brilliant. And all the new trainees, there has to be sort of class specific training and classes in this aspect. How to initiate the discussion of organ donation. Obviously, it will mean building up a rapport with the relatives, but how to initiate. Many of the consultants I've seen even today feel guilty while counseling about organ donation. So that's a very, very important aspect of communication.
And now that also we are now looking into or entering into the era of DCD, right? Yes. So that becomes more and more important, and because India needs the maximum amount of organ sort of harvesting or whatever you say that, and that's you guys are the future of it. And now we have Vaishali, Dr. Mani has joined. So I think that would be the so you can ask all the questions to Mani sir now, right, about the ethics and all others. So I give the responsibility of asking questions to you now. So Mani sir has joined, and Dr. Mani needs no introduction to all the candidates. So Vaishali, your question to Mani sir regarding both a little bit of communication, but mostly on the ethics also.
Okay, is he alive? Live online?
Yes, online. Sir, kindly unmute yourself.
Hello, yeah, there we are. I'm with you.
Good evening, sir.
Good evening.
Good evening. This is Vaishali here. And it's just such an honor to have you here on this platform. And I think the students are blessed to have your guidance in this. In my times, we didn't have such guidance. And end of life care decisions, counseling about end of life. We never had any guidance. We just learned on the job. We made errors, we made mistakes, and here we have reached. But these students are extremely lucky to have you already laying down guidelines. So if you would elaborate on these sensitive discussions, the two points is, one is the counseling about organ donations, especially with the DCD now, in the near future, maybe in the next 3, 4, 5 years, DCD also will come into the picture. And on the background of, we all have to accept that there is some amount of mistrust in the system in this country. And so on that background, it will be a bit of a challenge counseling about organ donation, whether it is DBD or DCD. So if you can give some pearls of wisdom about counseling the relatives about considering organ donations. And the next, of course, the end of life care decisions. I think the legality of it today, I know your tremendous efforts, and I think we are far better than what we used to be 20 years back. Every hospital had their own rules about, withdrawal, and there was so much confusion and cross consultation and cross opinions. So if you could elaborate on these two aspects, sir.
Sure. You see, first question is about the organ donation. Now we must understand why there is distrust. Distrust is when we link up our diagnosis of brain death, for instance, with organ donation. It's a huge conflict of interest, which nobody can miss. So the diagnosis of our brain death has to be delinked from the discussion on organ donation. That is the primary requirement across the world, and I don't know why this is not being emphasized on our side. In fact, we are diagnosing brain death only in the context of organ donation, which is a very major flaw.
Yes.
And we should not perpetuate this flaw. If we perpetuate this flaw, we can never bridge the gap of trust.
I agree completely.
So increasingly, we are fighting, even at the Supreme Court level, to modify this idea of brain death being linked with TOA only. Brain death is a diagnosis, a clinical diagnosis.
Yes.
And without that prerequisite, you can't broach the subject of organ donation, because the dead donor rule is inviolable. It is the basis. So, but we as doctors must understand patient psychology, that they shouldn't at all feel that they are being pushed into something where the doctor has a secondary interest. No, either monetarily or in pushing more surgeries or pushing something for our own advancement, personal advancement. You have a situation where brain death appears likely. And firstly, you talk about the likelihood of brain death and what brain death is and how we go about diagnosing it and establishing it. That is all, period. You're not going to talk about of organ donation at all now. Perhaps a coordinator, an organ transplant coordinator, can broach the subject when it seems very clear enough, not doctors. And then the approach should be that to enable the altruistic tendencies of the family, not that you should be doing this. This is an option available, you want to take it. The language is to be different. So an instructive request is not a request. Isn't it? Huh?
Has to be honest.
Instructive request is not a request. So these are certain basic rules, and it becomes even more important in a DCD. Because in a DCD, you are not a person, the death has actually not taken place, you are anticipating it.
Yes.
Right? You are anticipating it, and you're anticipating the, you are offering the possibility of having a non-interventional death. So you're discussing the prognosis, you're discussing the pros and cons of an intervention, and where that intervention seems non-beneficial, you offer the possibilities of withholding or withdrawal. And withholding and withdrawal both have within them implicit DNAR. Okay, there's no withholding decision without DNAR. Although you can take DNAR standalone without other withholding withdrawal. So these aspects of definition and clarity of the boundaries of each of these definitions has to be told to the students. The decoupling of an end-of-life decision and DCD has to be even more clear. Only when the family or the patient directly says, yes, I want to withhold and withdraw, or it's usually a withdrawal decision, so you don't directly have a family involved. They have arrived at a withdrawal decision. Then you broach the alternative, the possibility of a DCD. That again, firstly, the coordinator does. Once they evince interest, only then the doctor should move in. And even then, you can have the critical care and palliative care departments talking to the family rather than the organ transplant unit.
Yes, that there should be complete non-involvement of the recipient teams, and they have to remain completely non-involved till the final decision is made. So do you think that the general population, the speed at which they are catching up about their awareness about either DBD? I mean, I think even brain death currently, more than 50% of the population is not able to cope with the idea, not able to understand. So DCD is going to be a bigger challenge. Though, of course, on one aspect, it is less because obviously it's after cardiac death. So that is kind of a relieving factor for the relatives. But to be able to cope with the entire concept of DCD, do you think the rate at which medicine, intensive care, we want to go vis-a-vis how much the population can cope? Currently, there is, it's not congruent. It's not the same. And we have to be extremely careful. Otherwise, unlike some states where it has happened, it has got a bad reputation, and then the entire DBD program just kind of crashed in that state because, some elements kind of put a bad name to it. So there is, I think, we may be a while away from, though the need is there.
See, we may be a while away does not mean we don't attempt it at all.
I agree.
And the fact that awareness is poor doesn't mean that you don't attempt to make them aware. And we can't be so careful as not to attempt it at all.
Agreed.
So
Definitely.
I think, these nihilistic, nihilistic facts may be actually the ground reality. However, that is a very reason why we must make an attempt. Because without any attempt, no mountain is climbed anyway. And you have to believe that you can scale the mountain. See, I must tell you, even though we think these people still don't understand brain death, there are some states which are much ahead than the rest. Why?
Yeah, of course.
So we draw inspiration from Tamil Nadu and Kerala. We draw inspiration from Telangana. So why should we draw inspiration from Haryana where it is not done? We have got other examples. So what I'm saying is,
in these states, the government is extremely supportive.
Yeah, so you demand. When you create awareness, people will demand, and the government will do what it wants for the votes. So the thing is, and then even the judiciary will comply.
I think that's
the most groundswell of need will generate the political support and the judicial sanction. I think it has to be bottom up, not top down. Firstly, the doctor is the one who has to create awareness. He's the one sitting out there. If he or she don't want to take a step, nobody else is going to do it for us. They have no wherewithal to understand the necessity. So what I feel is one or two things are happening at the student level. One is they have no grounding in ethics at all.
Absolutely, yes.
See, they talk about law before they talk about ethics, which is a very sad thing. How can you talk about writing an essay without knowing grammar? So what has happened is why did we have the laws at all? Laws came from the principles of ethics. They have not come on their own. So the basic ethics they don't know. Or even if they know, they have not clarified their doubts. So it has not found its way into their practice. You know, most people have very vague ideas of what autonomy means and what our duties are. They think autonomy is some kind of a menu card, and you show it to the patient, it ticks it, and then you just implement and say it's your problem, right? If good happens, it is mine. If bad happens, your problem, because you chose it. So this sort of a defensive medicine is not ethics. It is hypocrisy. So we have to clarify. And I think for ethics, it has to be an interactive session. It can't be a lecture.
Yeah, people should come.
Yeah. What is it that you understand about autonomy? Why are you taking consent? If it's a paternalistic relationship, tell him this is what I think is the right thing to do. And this is what was happening for centuries. Why we are now taking consent? Which in our ancient wisdom we never did. Or elsewhere in the world, they were forcing it upon patients. You know, so we have evolved in the understanding of the human being as a person. And we have also evolved in our finding the right sort of balance, the relationship between doctor and patient. Not having a huge gap or gradient. And what do you understand of beneficent, non-maleficent? What do you understand of justice? So I think, you know, an ethics session which is interactive. You may have half an hour of ethics section where I would listen to their ideas, fill their ideas. What do you think? And where you are limited in your thinking or where you are all right in your thinking, that has to be discussed.
In fact, I would like to be in one of those sessions.
Thank you. Sir, I would ask you something. You being an examiner for years and also Vaishali, you have been training so many people. So what do you think, what is the commonest mistake the candidates do in an examination? So not restricting to the segment of ethics or communication, but overall in clinical examination, answer making and all others. So what should be they cautious of?
You see, in critical care examination, for instance, you know, in critical care exams, you know, the candidate is only looking at the monitor, looking at the lines, and looking at the lab figure. They're actually not touching the patient. You know, the biggest mistake I found is they don't even take the cover to look at the feet of the patient. They don't look at the skin of the patient. They're looking at the mean arterial pressure. They are not looking at the capillary refill time. They're not looking at skin color. Okay? And they are not looking at the pain score, right? On looking at the face. So I think what has happened is, you know, previously we had a sort of linear organized process in a non-critical care situation. Okay? History taking, inspection, palpation, auscultation. In critical care, all this was turned on its head. You start with ABC or BAC, okay, and then DE. So you lost somewhere the examination part. I think this is the biggest thing. I noticed this in the student.
Sir,
Whoever
we have in the
doesn't take the
previous-
cover off, who doesn't look at the skin, who doesn't look at the chest, how the chest moves.
Sir, in the previous sessions, we have very highly emphasized on this part. In fact, we have covered that very quick. Dr. Tushar spoken about a quick examination, the mandate of examination purpose, the prelude to the examination, including the consent, then privacy, then modesty, keeping the modesty and all others. So everything we have covered, and we have emphasized that it is the wholesome 360-degree approach to a patient. So clinical examination, assessment, data interpretation, integrating the monitoring parameters and everything. So all this thing in 15-20 minutes to come to an approach. So the first point is that the clinical examination and approach to a patient should be the priority, along with the information that are can be gathered from the papers and the monitors and the images and all others. What would be the next thing that
Next point is, we in critical care evaluation, we get lost in the physiological derangements. Okay, we get lost in the physiological derangements. We are looking at the heart rate, we are looking at the sodium level. Okay, we are looking at urea creatinine level. So we don't have a working hypothesis why it has happened. Okay, why it has happened? The question why. Diagnosing sepsis has become an end in itself. All right, sepsis, all the signs of sepsis are there, but what is the source? Okay, very few people are telling me what is the likely organ of involvement, or very few people are telling me whether there is a likely source which has to be handled with an intervention. Okay, so the whole emphasis on physiological derangement, diagnosing sepsis, and writing an antibiotic. So this is a problem. This is a problem of thinking. So you, after the ABCDE, you have to see what is your working hypothesis. And organ support has taken place. So, but they are not the end in itself. Then there comes the real problem of what is your working hypothesis?
So can we summarize in that way, sir, that not only a stabilization and making a working diagnosis, we should go towards a working hypothesis and move to our focus towards a definitive management. So what is the basic process that led to this unstabilization? Once I have stabilized this patient, now I should go to the crux of the issue and come towards a definitive management.
And there's one more last point where they are.
Yes, sir.
Supposing your working hypothesis and the treatment fails, then what are your alternative diagnosis and treatment plan? Supposing none of this has any likelihood of success, what are you going to do next? That comes the end of life care. So a comprehensive and critical care involves all this. Resuscitation, stabilization and organ support, formulation of hypothesis, then following up the response. And where response is not there or unlikely, then moving over the paradigm to the palliative care option. So this, I would say, is the structure of critical care, and where some of the elements are missing in the students' presentation.
I think Vaishali ji and me couldn't agree more of moving towards like this. And I always say that your work doesn't stop to my juniors to stabilize the patient, to correct the electrolytes, to just hike up or reduce the vasopressors. It is about to come up with a vasopressor and all and others, and also to have a plan B and plan C on whatever on a name. So you want to ask this question? So where are we for legal issues related to it? Okay, I will ask that, sir. And every time I get stuck, I call up personally Mani sir. So Mani sir, some clear as of now, the Indian legal perspective on direct withdrawal of life support? Are we allowed or not?
Yes, yes, without a shade of doubt. You know, constitutionally, we are absolutely clear, okay? As we have with the Common Cause versus the Union of India of 2018, it's very clear that you withdrawal, withholding are same. It's not that withdrawal needs some other law and withholding is the law. No, no.
Now, we always presumed, sir, honestly, we always presumed withholding was a softer version, and it is not dramatized. We are not just pulling off the tube. Rather, we are not putting up the tube. So if you see, sort of, it is less dramatic on that part, right? I didn't switch off the ventilator. I didn't do that.
If you take the drama out of it, if you look at it objectively,
functionally, objectively, it's same, sir. I agree.
See, for some people, you have a less dramatic medical management. For some people, you have a more dramatic surgical management. Both are required. Right, depends on the context.
Right.
Same way. If you had only withholding, no withdrawal, then you would be, what will happen to you? You will get either trapped on a ventilator, or you won't give a chance to anybody who can benefit from a ventilator. Yeah. So you don't give a trial of ICU care, or you decide to give put on a ventilator, the patient gets trapped. You know, if you discover after 2-3 days it's not working anymore, a patient condemned. Ye to ho nahi sakta. So if you have one and not the other, you will either undertreat or you will overtreat. So the law doesn't, the ethics don't separate the two. Beauchamp and Childress, in that seminal book, they do not separate withdrawal and withholding. They are same, because both flow from the same principle of intervention being non-beneficial.
Yes.
Either initiation of intervention or continuation of intervention is non-beneficial. So our law is clear on that. Number 2 point, the only problem that law did something wonderful in giving us the constitutional validity. That is why advanced medical directive is also valid. However, in procedure, they gave us a very complicated and unworkable solution. So to that, I will say to anybody who is interested, you can take these decisions on the basis of common law principle. What is common law principle? Anyway, before this law came in, we had the right to refuse consent. The requirement of consent implies that you have the right to refuse that consent. So after shared decision making, you arrive at a decision of refusing either to initiate a life support or continuation of a life support. That is valid anyway. And this is not only I'm saying, this is the opinion of legal experts of Vidhi Center for Legal Policy, as well as of the National School and University in Bangalore. So National Law School or University. So now the thing is, legal opinion backs up what I'm saying now. The informed legal opinion, because you shouldn't be asking just the lawyer of your institution. Okay, he may not be EOLC literate or experienced in that field. So those people who have gone into the subject are very clear on this. So once what happened was I found a legal luminary called Andhya Rijuna. You must have heard of him. He was the amicus curiae of the Aruna Schonbach case. I had a 20-minute long conversation with him. I asked him, sir, if I can withdraw and withhold, what does the law say? What is the bottom line? He said, doctor, that's your medical decision. Doctor, you feel it's not helping, go ahead, take a medical decision. These medical decisions don't really need a legislation. How beautifully he just, and this is a statement he has made in the Aruna Schonbach case as well. You can go through that. Okay. The usual medical decisions of stopping or not starting a medical intervention is a medical decision. And this medical decision, our medical community says, has to be arrived at
require a legislative approval.
Yeah. As a
yes,
consensus.
I agree with that.
No, so you arrive at it as a consensus, as a collegiate decision. So now, gentlemen and ladies, please if we should not be repeating the same question, we should be implementing this and then finding the benefit. Yeah.
Vaishali ji, any comment on this? Unmute, please. Yeah, you're muted. You are muted.
Sorry, I just said, one can keep on listening to Sir, and one would want him to just continue. But I know this is time limited. And if you ever arrange a session, as Sir said, about interactive, please include me in the student list. And I would want to be on that student list there.
Yes, there is, Pritima is also saying me too on that part. Sir, so
Wonderful.
we would be inviting you in 1 or 2 weeks time, and let's do something on the newer horizon, maybe on the different aspects or more commonly misinterpreted of the medical legal aspects, right? We had a lot of misinterpretation or sort of twisted interpretation of the medical legal angles.
Exactly.
And we really need certain. If you remember, sir, I called you up sometimes that what is the hierarchy of next of kin in Indian context, right? And sir, you won't believe I had almost 7 days of wastage of time to declare, because the dad was telling, okay, I will take this decision, and 2 daughters were saying entirely on the diametrically opposite, right? And you won't believe, sir, when I connected different lawyers and administrators, everyone had a different view out of it. So we'll discuss. If you remember, Vaishali ji, that
Yes,
patient.
yes,
right?
yes. I know it was our patient. Yes.
Right.
The
So
spouse
that's
has
how,
the first right. The spouse has the first right by convention. Spouse has the first right by our TOA procedure. Okay,
Right,
there
sir.
also you have to consult the spouse first.
Fair enough. Sir, so this is an exam preparatory, so I would have to restrict. Otherwise, we would have such an interesting session, but we'll connect very quickly, and I will ask Vaishali ji to coordinate that, to moderate that session and interact with sir and other relevant people. And thank you, sir, for coming. And sir, if you can please give some 1 or 2 hours tomorrow and day after tomorrow, maybe 1 hour would suffice. So we would be conducting mock examinations, long case, short case, table vivas and others. So if you can give a little bit of time on Thursday and Friday, it would be very nice, sir.
What time would it be? What time?
Good. Sir, any time between 4 to 10. If
Okay.
you give me, so if you just text me, Arindam, WhatsApp me that I am available on these certain hours, so I will place you accordingly. So there would be all parallel examination rooms. So you would be an examiner there, and someone will depose for examination to you, and rest of the guys will watch that. So you will take a predetermined or preset questionnaires would be there. You will take that examination, and at the end, you will give a little bit of analytics of that candidate's individual performance. And once all the examination would be parallelly happening, we finish it off, we'll come to a common meeting room and we'll do the debriefing of the case or table, whatever we are doing. So that's how
Sounds very good. Sounds very good. Your initiatives are fantastic. Arindam and Vaishali, I congratulate you on your initiatives.
All Arindam, sir.
Thank you.
Vaishali support everything.
See you.
Right. Thank you, sir.
Bye-bye.
And you kindly text me. Okay.
Yeah.
And thank you, Vaishali ji. I won't bother you. You are free to be here, or you can go ahead with your busy schedule. But I would love to have you over here, and time and again you can guide us for a better examination process. I will come to now my good friend Kapil Dev Soni, who is a professor in AIMS Trauma Center, and and I would like to have a very quick assessment that what the candidate should know about the trauma, because trauma could be a long case, short case, in tables and vivas and everywhere. And there are no other, because Kapil, I know you had been one of the pioneers in conducting ATLS in India. You are a trainer of ATLS. You work for trauma. You live, breathe, sleep, dream on the trauma itself. And God and you know that whenever I am in trouble, I do pick up the phone and call you and take guidance from you. So be it our high profile VIP cases or intriguing situations, I always fall back on you. So my great friend, And Kapil, it's over to you. Give our
Thank you.
candidates a little preview of it. Thank you.
Thank you, Dr. Arindam, and it's really a pleasure to talk about trauma, because that's the opportunity which, if I'm able to teach youngster, specifically who are appearing for exams, and that's a great opportunity. So as far as examination is concerned, and that too of a trauma, what I expect is the student should be thorough with the ATLS guidelines, because those are the standard guidelines, whether you work in India, you work in abroad, US, anywhere you work, that's the same language people who work in trauma, they would be speaking. So they should be very versed with the primary survey, secondary survey, the triaging of the patients, the ABCDE, and now that's the initial management of trauma patients. When would they intubate, and when would they put a chest tube? How would they monitor the output of the chest tube? When would they start resuscitation? The different stages of shock, the type of shock which is present in the trauma patients, hemorrhagic, non-hemorrhagic. How would they exclude non-hemorrhagic shock? What are the non-hemorrhagic shock like pneumothorax or a spinal shock or a neurogenic shock? What's the difference between neurogenic and spinal shock? About hemorrhage is one of the commonest thing which you most major trauma patients would encounter. And how to manage hemorrhage, what is the damage control resuscitation strategy, the damage control surgery, what are the principles, how much crystalloids a patient would be given, which crystalloid is to be given, at what rate, when would you start giving blood and blood products, in what ratio would you give, what are the evidence behind giving 1:1:1, what were the randomized control trial, the proper and the PROMIT studies. So these are the specific questions. And most commonly, if we talk about hemorrhage, there's the 4 classes of hemorrhage. The student should be able to tell me what are the 4 classes of hemorrhage, when would they order a fast examination or e-fast examination, and how would they interpret the finding of e-fast. When should a patient go to the OR immediately, or patient should be subjected to a CT scan. So these are the things which a student should be able to identify, take a decision on the trauma patients, and able to show us that the thought processes. So on the nutshell, trauma, what I expect would be about the management of hemorrhage, the brain, specifically the head injury patients, they should know the Brain Trauma Foundation guidelines. It means how much systolic blood pressure they would target in a particular age group. Elderly and pediatric patients, what would be the systolic blood pressures? How would they monitor the ICP? And how would they monitor the fluid therapy? What is the role of, say, tenexmic acid? The important trials which are associated with trauma, one was CRASH 2 trial, the CRASH 3 trials. So these are the important evidence and science which helps in day-to-day management of trauma patients. So that's what I would expect a student to know at least. Arindam? Dr. Arindam?
Hello, sir.
So 2 minutes, Dr. Kaur, I think is in a call. So just
Okay.
you can carry on.
Yeah. So these are the important things. What have been the changes in the new ATLS guidelines, and specifically what are the secondary complications you often encounter if a trauma patient is admitted in an ICU? That include the secondary complications, the rhabdomyolysis, the compartment syndromes, the limb compartment syndrome, abdominal compartment syndromes. How would they measure the pressures? What interventions would be helpful? And what are the complications they could foreseen in a patient who have got open abdomens, the infection, the ARDS. So the flail chest, how would they manage a flail chest, or a ventilatory strategy in specifically flail chest patients, or patients with the bronchopleural fistulas. So these are the important cases which one often encounter in ICU, and these are the trauma victims. And to the management of trauma victims always start from ABCDE. Once you start doing an ABCDE, that comes under the primary survey. Then the secondary survey, what the specific investigations that can be ordered. In case of head injuries, what are the investigations which can be ordered and how frequently it has to be ordered? What are the nexus criteria? What are the Canadian C-spine rule? How would they exclude cervical spine injury? So this important things one must know. The complications of massive transfusion protocols, the massive transfusions, they should be able to understand nowadays the ROTAM or a viscoelastic assay. If any center has a viscoelastic assay, they would be placing the various curves of the conditions of coagulopathy there, and how would that should be addressed in a trauma patient. That needs to be stated. Arindam.
Yes, I think we have aptly covered, and there could be, we have kept purposefully and separate table on ATLS, and we had tried to cover most of the components of the trauma itself. I'm not very sure whether there would be, but there were certain segments we were discussing at times that we might come up with some mannequins or simulators where we can have assessment of ACLS, trauma, and all others. I think Simant has also joined. Simant, he is also
good evening, sir.
a compatriot of Kapil, and he had been also one of the proponents of multiple courses, including the ATLS itself. So Simant, I think you can, if you wish to add something on Kapil, and both of you would be examiners in our subsequent the tomorrow and day after tomorrow's program. So please say a few words to our candidates.
Thank you, sir, for giving this opportunity. Actually, sir, recently we had one trauma case. The patient came from Agra. Already Dr. Kapil has added so many things, but musculoskeletal trauma, and the patient was not having, after 18 days, they have done put the external fixator, and because of this, the patient not having pulse, neither. When the CT angiography was done, it was torn external iliac artery. Immediately, it was well saved. What are the missed injuries when you are doing the secondary survey and the tertiary survey? The musculoskeletal trauma head injury patients, the most common injuries that those are missed are the musculoskeletal, whether it is sternum fracture, whether it is either a hip fracture or something long bone fracture or other fractures that is being missed. Concentrate on head injury and other things. Other times are something like that. In case of pediatric injury, they receive so many. They are ill treated. Because if you go through the X-rays, if they come with the injuries, they are beaten before, including elderly. These injuries are basically missed, and especially the trauma in pregnancy. Those women and all, they come with that, and how to do CPR in those cases. Slightly a bit, you have to turn the patient towards the abdomen, towards the left side, so that it is not causing pressure on the vena cava, and you can do the CPR. To apply whether the trauma in pediatrics, trauma in pregnancy, trauma in elderly. And important thing is, you should not forget, you do the triaging and the pre-hospital trauma. The person who are involved in doing resuscitation of the patient outside the hospital, that is most important. What they have done, whether the patient has received, because I don't know in India, but outside India, US and other, they are very much trained. They are putting all the supraglottic devices. They can even intubate. They do everything. So those pre-hospital traumas shouldn't miss, because once we receive the patient and whatever we are doing, those things are very important, including pre-hospital and triaging we are doing, and including all the patient, what patient has to take in the case of mass casualty, which patient has to be taken to the ICU, and which patient has to be kept in the, when you have overwhelmed your facilities, you don't have that much resources. Those things, triaging is very, very important. And suppose you are working in a primary center, Dr. Kapil is working in tertiary, he's fortunate enough, that is one of the best in India. But you are working in a primary center. That time it's very difficult. Suppose you are having head trauma and other things. You do primary survey, you do secondary survey. But the important part is you have to shift the patient to a definitive center for the definitive things. And transporting the patient, sir, even you are taking the patient from ICU from one bed to other bed. So patient's vitals are getting destabilized. And we're talking about taking the patient, either you are taking the air ambulance, it has got its own advantages, disadvantages. And by road you are traveling, the patient is traveling. So taking time is it's very difficult to manage the patient primary survey. So we have to think about shifting the patient to a definitive center. And especially the two injuries, that is the life-threatening could be, because a head injury patient is not going to be in shock. Isolated head injury, unless it is combined with you have to take care of your tension pneumothorax and your pericardial tamponade. Two things has to be taken care of and included in the five. And especially we are missing this muscular. So these things, sir, we can say, and we have to do sir, important thing is whenever we are doing, tackling the trauma patients, it's not that easy of securing the airway in those trauma cases when you have got some laryngeal injury, other things. Those are not the simple things. It's how to take care of the airway. Airway has to be secured. So those are the important things because a patient will be killed. First thing to be taken care of is airway. So trauma cases is very difficult, and CPR is also going to be very difficult. Once I was a 7-year-old boy. He came. He had he failed chest. He was having a long bone injury. He was having head injury. He was having abdominal injury. Sir did the resuscitation and put central line everything. He underwent 7 surgeries, and patient was saved after discharge after 3 months. So well done. When we have known case also recently, we saved that patient from that limb was saved. So important thing is the golden hour is to be taken into account. When we had 6 hours for your limb injuries, for doing the angiography and the other things, and you have to involve your vascular surgeon. So these things are very, very important when you are tackling these trauma patients. Thank you, sir.
Very nicely said, both Kapil and Simant. And I would say that one of the major reasons that why trauma is important in intensive care is that normally it happens to younger people, and it is very, very satisfying because you can save certain lives which are not supposed to go, right? Because you are saving some young lives who as well ahead right. As of now, you are giving we were managing 2 high profile the Bandra Sea Link accident, and one of the major person who died, but 2 other survivors we saved and others. And the other thing is that it is a test of your not only your promptness, your procedural capacity, your decision making, but also integration of all the information that is coming to a polytrauma patient. So many things are happening parallelly, and you as an intensivist is the master of the symphony. You are coordinating everything and taking the decision towards the best interest of the patient. So that is being tested, that your knowledge, your decision making capacity, your aptitude, your procedural skills, everything is being tested in a trauma. So I would, if there is a trauma patient, polytrauma patient in the unit, definitely that is being included, would be included into the long case. Do you think, Kapil, that would be in a long case?
Definitely. So what we do, I also go for some examinations for DM or critical care examinations. We put CT scans, we put scans of head, we put even scans of abdomen, thorax as well. And we ask the student to identify that can be kept as a short case or just during a viva voce, we ask them to identify, read the CT scans. So at this super specialty level, it is expected that a student should be able to read a CT scan. So that's a minimum what we expect from a student who is passing through a super specialty course, that they should be well versed, because these days just knowing X-ray won't suffice. You need to know the different CT scan. They should be able to identify different type of pathologies, the EDH, SDH, splenic contusions, liver contusions. They should be able to identify, or a lung contusions. They should be able to identify. So that's normally what we do when we go for examinations.
you, and I hope both of you would be there tomorrow and day after tomorrow.
Yes, sir.
Kapil
Sure,
and
sir.
Simant, kindly
Sure, sir.
put your availability and WhatsApp
Sir,
me.
what time?
And
What time, sir? What time?
From 4 to 10 in the afternoon.
Yes, sure, sir. Sure, sir.
Then kindly put your availability. You can stay all through, but you can also choose to be for certain period of time. So just let me know what time you guys are available, both of you, and you are free to leave, or you can stay and take part in the conversation. It's an open chat session and send. So
Yes,
I
sir,
think
I will be there.
okay, so Ghansham has joined, but I will first come to Farhad sir, as he has joined and he has come for a as is for a limited period despite his busy schedule. Welcome, sir, and one of the most accomplished teachers, physicians, intensivists, and senior, one of the most dynamic person, our ex-president of ISCCM, and I have never seen a better orator than Farhad sir. So, sir, first I would like that you give a best wishes to our candidates. They're a little tensed, and because they're not aware of the format of the exams. So this is the first time three-year course batch coming. We are contemplating that or extrapolating that it would be something like the DM examinations, but we have also taken a little liberty to imagine ourselves that how the exams would be. And there are only 2 to 3 weeks remaining. So some comforting words from your end would soothe their nerves. Sir, it's all over to you.
Okay. Can you all hear me?
Yes, sir.
Okay, first let me start by wishing you all the best. The second thing I would say is don't be too concerned about the format. Okay. Most exams are designed to see how much a candidate knows, not to push the candidate in a corner of this thing. In a way, you'll end up being better prepared if you don't know the formats, and you'll sort of train yourself to think on your feet a little bit. And I think, you know what, I mean, ultimately they can give you a short case, a long case, some x-rays, some slides, some case scenarios, some reports. It's not sort of too hard. So I don't think you need to worry too much about the format, as long as your sort of basics of how to obviously look after a critically ill patient are sort of in place, and B is how to show the examiner that you have that knowledge. And I think at least in my years of training, I'll ask the most simple thing, and when the student goes into exam mode, they're unable to give an answer, which I know they know. They do it every day on the ward round. But somehow when it comes to the exam, they sort of go into an exam mode and I ask simple things like, give me 3 important causes of loss of consciousness, and suddenly it'll start with, I will go neuro, I will do this, I will do that. So I will just, the advice I will give you is you just need to show the examiner that you know how to competently look after a critically ill patient, no matter what the rest of the context is. The trouble with examiners, I don't want to discourage you, but it's a bit of a hit and miss. Each examiner has their own wants and likes and dislikes and biases, but that's sort of part of life. I think you should just focus on trying to convey to the examiner that you know your job, you're experienced in it, and you are a safe pair of hands when you are asked to A, look after a critically ill patient, and B, make the system work in the ICU. I mean, as an intensivist, the simplest part of the job, honestly, is the clinical part. But making the system work, making results right, making sure consultants who have differing opinions all agree to a same line of treatment. So you got to sort of show the examiner that you know how to look after patients, and you know how to execute that knowledge in the context of real world ICU with all its varying pulls in different directions. I actually, when I agreed to do this with Arindam, I think what works best for me is you all ask me whatever questions you want, and I'll try to answer as best as I can. Okay, and sir, we'll take it from there.
Okay, so I would be the devil's advocate. I would be asking you the questions. So first of all, at times even I had gone through this process, And we were always intimidated by the big name examiners like you, right? So how to deal with that on a student's perspective?
I don't know what to say. I mean, I think if you're well prepared, you don't need to be intimidated. I've often told this story. It happened to me about 10 or 15 years ago, or maybe 5 or 10 years.
Right, sir.
12 years back. I had started appearing for some music exams, and I was doing it at a very junior level. And in the morning, I had to give a talk about ARDS to about 250 doctors in Hinduja, and absolutely nothing they said would have fazed me. And I would be very happy to say I don't know the answer if I didn't know the answer. But in the evening, to perform in front of a small crowd, I was a shivering wreck, basically. So the difference is how well you're prepared in the exam. I mean, in your topic. And if you're well prepared in your topic, you just got to have faith in your knowledge. And it's very unlikely you will then trip up. As long as you have the knowledge to back you up, don't worry too much about the reputation of the examiner, because ultimately the treatment of a heart attack is a treatment of a heart attack, regardless of the examiner. The treatment of how to intubate someone is the way you intubate someone, regardless of the name or scariness or position of the examiner. So just be confident about your basics and stick to the basics. That's what I would say. The second thing I would say, this is something I learned in MRCP. Some examiners give you enough rope to hang yourself. Don't get too carried away. Stick to the basics. Say what you do. Don't sort of overshoot your remit in a question, and give the examiner a chance to ask you a question which will be difficult to answer. So just sort of stay focused on the question. Say this is the way you would do it. And then if there's a leading question after that, answer that. But don't go on and on and on and give the examiner a chance to let you dig your own grave.
Come up here. Come up on that part. Exactly, sir. Sir, the different what perspective I can ask you is that the commonest do's and don'ts for a candidate in an exam center and an exam process.
I mean, obviously, the biggest do is be well prepared. There's no escaping from that.
Right, sir.
Now, the second thing is, in an ideal world, the examiner should be full of no biases and should be able to see your knowledge for what it's worth. But examiners are normal people and they have biases. So don't present yourself in a way which might trigger off some negative reactions in the examiner. So you don't have to sort of overdress, but don't be casual in your dress. Be reasonably well turned out so that the examiner gets the sense that you're serious about this. So that would be the primary do's, is don't be too casual about the whole thing. I mean, don't just understand that your examiner will have his or her own biases, and you should not do something which we can trigger it. Now, sometimes it's just unfortunate. You have an accent or you have a hairstyle which the examiner doesn't like, but there's not particularly much you can do about it. But try to keep your presentation as neutral as possible so that the focus stays on you and your skills rather than the examiner biases coming in the way. I don't want to give very specific examples, but I mean, I know there's been a time when one examiner said, "Oh, you guys are from Bombay. Let's see how much you know." So this was in some other. So now here the guys from Bombay. So these kind of things exist, and you just have to deal with it. I mean, life throws different things at you, and you got to sort of deal with this. But in this particular exam, your focus has to constantly be on, this is the way I look after critically ill patients. These are my skill sets, and this is my way of presenting my skill sets to you. I think that's it. And don't dig your own grave. If you're asked, how do you intubate someone, don't say, I've done 1,000 intubations in my life and never once have I failed, and so on and so forth. Just say, this is the way I intubate someone.
So one suggestion came from Srinivas Samavedam, is that do not present yourself to be very shaky and nervous in the day, because we as an examiner, or we are assessing you that you would be confident enough to manage a critical care unit. So even you should be presenting yourself as more confident, more assertive, clear, with a good communication and quite articulate in that day. So no fumbling, no inconfident approach, no
I don't
shaking.
I don't disagree with that, but unfortunately, really unfortunately, it's not in your hands. It's not that you have a switch you can turn on and off confidence. So what will bring the confidence is your background knowledge. I mean, I gave you an example of me doing something in the morning full of confidence.
Yes, I got it, sir. At the moment you are there,
I would like you to be confident, but I have no way of knowing how I can turn on and turn off confidence. The only way you can be confident is know your material well and hope you don't get stuck in some silly question which you're completely clueless, and that's part of life. But the more you know your subject, the more likely you're going to give a reasonably good answer, and then the more likely your confidence levels will go up.
And the other thing is what he's also added is that don't hesitate to be apologetic, be transparent and honest in your answers. Don't hesitate to be apologetic that if you have committed some mistake, get back to it. I think that could be a very good day. Ghanshyam, do you want to add something? Because we almost started together being into your experience on the exams, and what do you want to share on that?
I think I agree with most of the things which Dr. Farhad has said. Yeah, just a couple of points, Arindam. I mean, at least for me, what I have done in my exams is if I didn't know the answer, I wouldn't wildly guess. I would just say I don't know. Okay. And intensive care is such a vast thing that depending upon the unit that you have trained, there could be some scenarios where probably you're not familiar. And we all agree that we have learned a lot of our intensive care after we have completed our courses. So if there is something that you have not seen or you're not familiar, you don't know, I would be upfront and say, sorry, I've not seen it or I don't know, rather than keep wild guessing. And that's where you keep, as sir has said, you'll be keep digging your own grave, where you'll be guessing, and go to a point where you're committing one blunder after the other. A simple, I don't know, will prevent you from doing more mistakes and more blunders. So that is one thing that I would expect the candidates to be upfront if they don't know. And second thing is, sometimes, we do a lot of things, but you tend to forget the theoretical kind of basis or the way you formulate your answer. So if you are in that kind of situation, just go back, keep your calm, remember what you would do in your unit on the ground, take that as the cue or start speaking about what you would do on the floor. That should take you or just guide you through those difficult situations.
That would be very nicely said on that part. Yes,
I agree with that. One of the ways to build your confidence is to have a lot of mock sessions with each other. One person present the case, one person asks questions. It doesn't have to be a teacher, and the third person answers. And the person watching says, okay, you missed this, you missed that, and you keep doing that. So you make the mistakes in your practice session rather than making it in the actual exam. Just take a full series of cases and just keep this thing. Read the ECG. How will you deal with this? This patient has come, and keep practicing it. So you sort of got the basics right. Now, I always tell my candidates, you always start with, I will check the ABC. But now if you're told that the patient has given you history, don't say that. But if you're not told, just start by saying, I will make sure that the person is breathing and I can feel the pulse or the person is communicating. So the more you practice this, the more you have a structure when you're actually answering the exam. And the best way to practice is just keep running a series of mock tests, either with your teachers or with your colleagues or with your senior people who already passed the exam. Or you can even do it with your contemporaries or even with your juniors. All you need is to keep repeatedly learning how to present so that the flow is maintained during the exam rather than trying to create the flow during the exam.
So if I can summarize on the do's, right, that on the exam day, you should be presenting yourself as your own self in a clean dress, sort of close to formal, right, a dress that you wear on a normal Monday or Tuesday, right? Some say that you should be clean, no fancy cuts, a proper shave, nothing on that part. Let's not trigger the biasness or sensitivity of an examiner itself, right? Put on the standard, the IC infection control practices when we are approaching. I think the aprons are gone, particularly in critical care examination many of the times. And in European examination, we trained when it was in a physical format, we used to train the candidates that the sleeves up, no nothing on the no watches and all others. The way people actually do enter an European ICU, something of that sort. And good smell, good brush wash and all others, and carry your standard things, particularly a pen, your identification, logbook, thesis book, and all others. And also carry your own self, your character, your confidence, and your knowledge with yourself. That would suffice. So I think you would agree on that part.
Yes.
Okay. So now I will come to Ghansham, and I will ask Farhad sir to ratify Ghansham and add up something if both of us misses. I have asked Ghansham to give an idea about that what should be the different procedures, devices, and equipments they should be aware of, which could be possibly be asked in the examination. So be it in within a long case or short case scenario, or be it in a separate table.
I think Anindam, see, by the time you have come to this station, you would have finished both your cases or whatever long case and short case was there with you, and your mind or your mood could be different depending on the how the cases would have gone. Some might be having anxiety, some could be having the stress that probably the cases did not go well. Or what I would suggest is take each station as it is, right? Don't let one station impact your performance at the other station. And so most commonly the procedures, the devices, the equipment are something which we kind of are familiar and which we would be using on a day-to-day basis. The only thing is, when you ask a question about a particular procedure, take some time out, think about how would you format your answer, enable simple indications, contraindications, the kind of safety measures that you would take while doing that procedure, maybe a simple checklist, and have clear idea about the landmarks, especially simple things like a central line or arterial line, or if somebody asks you how would you intubate, see, nobody's testing, or nobody's going to, I don't think so, nobody's going to allow you to do it live on a patient. They are looking at, if you are in a situation where you are going to intubate a patient, then people are looking at whether you will be able to do it safely or not. So very simple procedures as to keeping your equipment ready, the checklist ready, the kind of drugs that you would give, what kind of tubes are you going to place, whether your laryngoscopy is ready or not, whether you have made an assessment of the airway or not, and if it's going to be a difficult airway, whether you have kept your difficult airway on the backup or not. So that is these are some things which we do day in, day out. The only thing is we need to take some time out, format your answer so that you go step by step. And that creates a lot of impact on the examiners. It makes the examiners feel that, yes, you have spent your time in the intensive care unit and dealing with patients and, kind of being involved in all the procedures. So that is, I think, very, very important. Since usually these stations don't have much time, so formatting your answer becomes the key.
So I would say, okay, Farhad sir.
I don't have much to add, but whenever I check a candidate's ability to do a procedure, or make it a point to introduce themselves to the patient and to explain to the patient what they're doing before starting. It leaves a good impression with the examiner, so that you, of course, if the patient is deeply sedated, you'll say, if the patient is, I'll explain it to this thing. Make a point to say that I will take the consent or see that the consent is taken. Make it a point to say that I will, whatever, I'll check all my equipment before I do this procedure. If you're doing a tracheostomy, make it a point to say I've checked the coagulation profile. So the examiner gets a sense that A, you're prepared for the procedure before you start, and B, the examiner is very clear that this is not a sort of blind drill you're doing. You're actually looking after a live patient, and you're looking after the consideration of the pain and the discomfort and the nervousness of the patient as part of your procedure. Not only I've got this landmark and I put that line in, I put this guide wire. So I really like it when my candidates start by saying, this will be my preparation before I do the procedure, and I will introduce myself to the patient, and I will explain the procedure to the patient before I start. I would only like to add that. Otherwise, I basically agree.
Okay,
and
so I can
to repeat what I'm saying. You'll only do this well if you practice it 1,000 times with your colleagues. You say you practice it. How are you going to intubate someone? You practice it 100 times with your colleague. How are you going to put in a whatever ICD? You practice it 100 times with your colleagues. Then you won't make the slip ups.
Thank you, sir. So I can summarize in that way that approaching a procedure, if you are to enact a procedure in a simulator or in a imaginary situation. So the first and foremost is the validation of the indication and contraindication, preparation and planning of this entire thing. Then explain in the own words and comfort the patient itself and take and recheck the informed consent itself. Be absolutely sure on the process that you are adopting is safe, both for the patient and for you and the unit itself. Have the preparation and planning strategy in place, including the contingency plan, that if the plan B, if there is any other complications, you will fall back on whom or what. That is an NA. Then execute it in proper way, making sure the patient is absolutely comfortable and safe. And then once you are done, you confirm it, you validate it, that it has been happened and it has served its purpose. And there are no iatrogenic complications that are developed during the process itself. So that's how you should approach. And as Farhad sir has said, that you have to have multiple times of practices so that you enact this entire thing properly. And this will also help you to do these procedures day in, day out, you are doing in real life also. So that's the thing. Ghanshyam, anything to add?
Only add that always make it a point to introduce yourself. And quite often...
And sorry, I introduce, yeah. I will write it down.
Are quite often intubated, so you don't know which language they're speaking. So try to do a sort of bilingual, at least I do English, Hindi sort of, I can make sure between the two of them.
Sir, should the introduction be also including that, okay, I am Arindam and I am senior resident and I've been quite sort of reasonably experienced in doing this procedure, and today I am fortunate enough to do the procedure for you, and I'm sure that it would go well with the overall systems. Should we introduce like that?
Well, yeah, sort of. 1,000 procedures. What I'd say, I'll be doing this procedure and I'll explain it to them. You'll get some local anesthesia here, then the needle will go in. Don't worry about it. And if I need something from them, especially if I need them not to move, then I'll explain that before. That please don't move when the needle is inside. So then I'll explain that to them before.
Fair enough. Ghanshyam, you want to add something?
I think sir has covered, in a nutshell, pretty much everything that you would need it. Yeah. If I mean, just a part of the consent. I think if the patient is unconscious and if some examiner wants to kind of test whether you have actually taken consent, then he may ask the candidate to explain about the various complications and how would he kind of explain those things to the patient's family in a reasonable way. He should be able to kind of convey the complication at the same time, give him the confidence that he'll be able to handle them. How many of them are really,
and also also the concept of risk benefit ratio.
Correct.
Then we have all the good measures to prevent complications. God forbid if it happens, we have also measures to take care of the complications so that it doesn't.
Just establishing the transparency in the way.
Yes. And in fact, we have explained that in a communication sort of scenario, there could be a scenario where you are asked to take an informed consent from a aggrieved sort of, or a little bit mildly hostile patient relative, right? So that sort of scenario or communication scenario would be also included in that practice session. So that's how we have approached. So thank you, sir. And I hope you would be there tomorrow and day after tomorrow. If you can please spare some times between 4 to 10. Ghansham has excused because he has a big conference to be organized. So thank you, Ghansham, even for coming for us. Your support has been quite exemplary, and we had been friends for almost now 15 years and ever.
I remember when I gave the exam, I was in your room at Gangaram's.
Yes, yes.
I spent the night before with you, Arindam, and that calmed me down.
Yes.
Just want to wish all the candidates the very best of luck. See, basically, all of you have come to this extent. I mean, you have finished your masters. You have now want to give a super specialist exam. I mean, so we all have that kind of a intelligence, hard work. It's just that on that day, for a couple of hours, you just maintain your calm, composure, recollect what you have done over the last 3 years or more than that, and you should do it very well. Wish you all the very, very best of luck.
Thank you for being here. And Farhad sir, please, if you can spare some time, just text me in WhatsApp that what time would be possible for you tomorrow and day after tomorrow, whatever time. Even if you take 1 or 2 exams, that would be beneficial for all the candidates and us also.
I'll text you tomorrow and we'll take it from there.
Okay, sir. Thank you, sir. And I will send you all the sort of guidances, because it's a little.
If any candidates specifically want to ask me questions, I think that will be, I'll be happy to answer them.
Sir, it is always an open chat.
You can ask it in the chat or directly.
Or candidates, yeah, you are open to ask question to sir. Anyone? Why you have to come up out of your shell and ask some good questions to sir, or even some not so good questions also. This is an open forum. Okay, so if you are, you can also
just
put it
one
in the chat box. Yes, please.
Arindam, one tip. See, you would know which center you would be going to practically, right? Practicals. So where are your practicals? Now, some centers are very well known for certain aspects of intensive care. So if you get first-hand information of what your center is, then maybe it's it's always worth a shot to kind of know what are they really good at, and maybe being familiar with those procedures or being familiar with the kind of interventions that they are very good at, you always come in handy. It's just a smart tip.
I think that would be very. I think Rajat is okay. So one question, Farhad sir, for an unconscious patient, should we ask examiner to allow me to speak to the next of kin for consent or history?
Yeah, why not? Absolutely.
I think this is, you should follow, Rajat, you should follow the normal standard process. If the patient is unconscious, you should seek consent for examination, and you should seek that part. You should show that you know the process and you have asked for it. 100% of times the examiner would say, okay, the consent is implied, you go ahead and do that.
Because see, that is what
save the time.
Arindam, that is what we do, isn't it? If the patient is unconscious,
yes, that's exactly what
I mean,
we
you
do.
kind of talk to the next of kin or next to the doctor, somebody else who's there. You don't talk to the patient. So yes, you should do that.
So that's a very good that the consent part, if the patient is unconscious, you should ask that I would seek a sort of consent or from the next of kin, and this is that you show that you have concern for the consent, and 100% of time the examiner will allow you, will say that the consent is already there, you can go ahead, but you should ask for it, right? You should not take on that part. Sir, is the discussion will start straight away or they will wait till our history finishes? So I think the history part, unlike the medicine examination or something of that sort, I think it's more of your presentation in a nutshell is more important. The discussion part is more important. What do you think, Ghansham?
It depends on the examiner, Arindam. I think, see, there could be some examiners who might want to ask questions the moment you start presenting, maybe based on the symptoms about what your differential diagnosis would be, and then how would you proceed. They may not want to wait till the entire history is finished. So it kind of depends on the examiner. I don't think there's any fixed format that somebody has to finish the history and only then questions would be asked. So it can be anything. I don't think it will be anything which will be very different from the routine questions. But the thing is, the questions may be at different. Some examiners might want to listen to the entire history. Some might want to just intervene at some point of time and take the discussion from that point. So,
okay. Anything else? Any other questions? We are almost on the finishing part. There's 5 hours straight away that we had been ongoing. Okay. So in do's and don'ts, I think we have done most of the things, that presentations and your attitude, and many a times we have seen candidates being arguing.
Okay, I think Arindam, sir, we get the history only from case sheet, right? So there's somebody who's asked this question.
No. You see, the whatever the case sheet, many a times there would be a preformed case note, because it is at times, for example, our patients, we have patients who are staying here for 10 days, maybe referred from another hospitals where they are stayed for 20 days and all others. Quite a complex sort of patients, right? It's unlike your general medicine patients whose history could be very straightforward or simplistic on that part. So many of the times the case notes are there, and there would be some people who would be a first year or second year DrNB or a DM candidate who is supporting you to gather the information, because the time is too short. So your history would be your examination, your analytics of the case notes, the case A. So everything put together, the investigations, the feedback from the monitors and all of that. So what I would do is that I will give you a very quick review that how to put up your A. So which will include that how to, or what we teach in the European exams, that how to approach that A. So this is your history, this is your clinical examination, this is your investigations, the monitoring devices, the organ support devices, the drug chart, and all put together. So I will give you a format which will make it much more methodical to approach. Yeah, thank you. I will give that. Anything else? Okay, so we have only, did Amrita join? I think Amrita and Proloy was supposed to come back.
Arindam, I should congratulate you for the phenomenal effort that you have put in to help these guys. Good luck, all of you.
I think it was, we owe them, right?
We owe them. Right. I agree, we owe them, because this is the first time
our future generation. So I would have loved that you could have joined for only one session tomorrow or day after tomorrow. See how it is.
I will text you. I'll text you.
Okay. Right.
Somebody has asked a question.
Do you have any case pro forma format that can be useful? Can it be applied of? Yes, I will do that. I will make that. Shankar, I will do that. I have something ready on that part. Case pro forma format. I will not case pro forma, that how to analyze a case, right? How to be ready for the case and how to do that. I will do it for you guys. Anything
okay,
else?
Arindam.
Okay, thank you. Dr. Darshana, you can take a leave. Ghanshyam, you are busy. Thanks for coming. And
thank
please
you,
text me at least for an hour if you can join.
Sure. Okay, Arindam. Bye.
Any time between 4 to 10. Dr. Darshana, she had been busy little on the the accreditation going. Yeah, Sachin is here. Okay. Sachin, if you can quickly give us a name. Sachin had been one of my strengths, my colleague, my support, and he has preceded as an examination secretary, and he had done a wonderful job for ISCCM, being the controller of examinations. So today Sachin is going to give a quick review on, as already Dr. Deepak and Vivek has given a little bit of hint of it, but I would ask Sachin to give an idea that what should be people reading or be prepared about the imaging, particularly the ultrasound, and but also a little bit of the imaging. Sachin, is all yours.
Yeah, thank you, Dr. Arindam. So, see, ultrasound, as we said, we don't know the format, whether it will be a paper exam or on a bedside exam. So ultrasound basically can be a part of your long case management or short case management stations where you can have your ultrasound clips displayed, right? So one should know the basics of ultrasound in terms which probe to be used for which kind of examination. For example, if let's say in your case scenario, somewhere a consolidation comes into the picture. So one should be aware of what are the ultrasound findings in consolidation, how to appreciate them, how to differentiate it. So you should know the differential diagnosis of these lines. For example, what are B lines, right? So you should understand if you say, I see B lines on the lung scan. So you should know which all etiologies will show you B lines. And then how do you differentiate that? Is this pulmonary edema? Is this consolidation? Is this lung contusion? Is this just an interstitial edema? Is this a nodule or a malignancy? So these features should be there. So you should understand and remember what are B lines, what is A pattern, what are the classical signs of consolidation, similarly atelectasis. Again, if let's say you do an intubation, you say I will intubate these patients, apart from your 5-point auscultation, can you also determine it with the help of ultrasound? So ultrasound will be an adjuvant to all your existing support systems, all your existing examination part. Similarly, forming a diagnosis. So you should know your basics of echocardiogram. We all know that if there is a massive pulmonary embolism, echocardiogram per se can lead you to thrombolysis. So you should understand, you should know what are the findings in echocardiogram, how will you do it, which areas to be scanned, what are the fallacies in that scanning, what are the various measurements that you will do it. So these have to be understood. When we talk about fluid assessment and, as per the surviving sepsis, we give 30 ml per kg, but is there any other way of assessing fluid responsiveness? You do your PLR, but what about ultrasound? So you should know how to calculate velocity time integral, because see, ultrasound can form a part of each and every case because it is a kind of examination. So those all things should be aware. You should know how does an ultrasound clip appear in pneumothorax? What is the lung point? Because it can be a part of your investigation table also, just a scan being showed there. So these important features should be very well aware. Now, when we talk about other parts of radiology, apart from ultrasound, X-ray. So how to describe an X-ray is important. We should know, is this an AP view or a PA view? Is this a male patient or a female patient, if that is possible? Which day and date has been done? Is it correctly placed? Is it rotated? Is it under exposed or not? And then the findings. So either start from in to out or from out to in. So either you can start from your skin, subcutaneous tissue, rib cage, lungs, and the cardiac border, or from inside to outside. So it has to be a systematic examination. And this goes for all kinds of radiology, whether we are talking about X-ray or a CT scan. Remember, whenever you read a CT scan, always be clear in two things. One, is this a CT of a chest or a head or an abdomen? Is it a contrast-based CT or a non-contrast-based CT? And you compare it with the vertebra, right? The whiteness of the vertebra. So always remember to say, is this a contrast or a non-contrast CT? And then you describe the findings again, either from out to in or in to out. So be systematic in your examination, because it looks very easier and crispier to the examiner to hear out. I would say for ultrasound, be prepared, because nowadays ultrasound is in, every center is doing it. Your examiners will expect you to know the basic features of ultrasound, the findings in various etiologies. So how does a DVT scan is being done? How do you assess your fluid responsiveness? What are the lung findings? How to do an echo, how to generate a 4-chamber view or a 5-chamber view. So you should be aware of these terminologies and what all chambers, what all structures are identified in these things should be done. As Ghanshyam was talking in the previous about procedures, right? So while let's say somebody says, how will you put a central line? So yes, you take your due consent, you prepare you this, and you can also add, if I have an ultrasound in place, I will take the help of ultrasound while doing it as a real-time central venous access, because it adds to the value of what you're doing. It tells the examiners that yes, you are aware that ultrasound is nowadays almost mandatory when you want to put a central venous access. It's a part of various quality indicators. So you can tell this in your clinical examination. Arindam, this is what I wanted to add. Yeah.
Sachin, any good words for the candidates? Anything that you had conducted so many exams, you had been the controller. So any tips, any clear on that?
See, always remember, answers are very simple. We make them complicated, right? So if somebody says, what are the causes of respiratory failure in a patient? Please start from simple answers. Don't go to the last choice answer as the first choice answer, because always remember that you are at the bedside and this is how I will start, examining my patients. Just keep a verbatim of what you are doing it. So be very clear, very simple in your answers. The examiners don't want a very hi-fi or a complicated answer. We are looking for simple questions, simple answers. Again, as everybody has said, don't get intimidated by who is sitting on the other side of the table. Remember that they're just asking questions. They're just trying to test your basic knowledge. We want the basic knowledge to be judged. The principle is, will you become a consultant and will you be able to handle critically ill patients, both clinically as well as administratively? That is what at least we are looking when we are looking at DrNB candidates, right? We are looking at a course where if this person passes, will I be able to take him as a consultant in my unit? And I am rest assured that he will take utmost care of this patient, both manners. This is my point.
I think excellently said that both clinically, ethically, legally, and administratively, our patients would be comfortable, patient's family would be happy, and overall the system would accommodate the new entry person on that. So that is sort of expectation we do have, and let your, as Dr. Banambar Ray said, that let your answer be in layer like an onion, right? So do not give everything at one go. Let the examiner have an sort of chance to ask you more and probe you more, rather than you give it at all one go. So that's also gives you more time to express yourself. So that is a very important, and that will come on that part. So thank you, Sachin, and please let me know what's your availability tomorrow. Please do message me. We have an excellent mock test, everything ready. Long cases, short cases, 12 different formats of Viva, OSCE, and everything is ready. So you just let me know. Tomorrow's engagement is between 4 to 8, and then the Fridays is between 4 to 10. But we would be happy to have you any point of time. You just let me know your availability. We'll accommodate you accordingly.
Thank you so much.
Okay, and thank you for coming. Namaskar. Okay, so we have Rakesh Garg. Everyone knows you, Rakesh. You are a star, and you had promoted the not only anesthesia and critical care, but also you had brought the airway management in different segments, be it in anesthesia, be it in critical care, in any difficult situation. You have promoted it like anything, and for thanks to you that many people have learned the nuances of difficult airway management. I will explain you, Mr. Dr. Mohan, that how do you know your candidate number and others. At the end of this session, I will explain what would happen tomorrow. So let's hear from Dr. Rakesh that what are the airway station that could be in the examination, be it as in a within a ambit of the cases, or a short cases, or as a separate table, or in the grand viva, maybe in a simulator, how to approach quickly and what to learn and what is expected from a candidate. So be it your standard airway management or a difficult airway management or an emergency airway management. Over to you, Rakesh.
Thank you, Dr. Anandamkar, and I must acknowledge and appreciate your great effort towards this teaching training of our candidates who are doing various critical care program. So I think hats off to you for, and I'm seeing you since morning, you are doing a lot of effort. With regards to the airway, when we talk about the airway for critical care, I think this is one of the area which can be asked at any point of time. Whether we talk about the theory exam, or it is OSCE based exam, or a short case, or a long case, or a grand viva, or even in case of if somebody is going for viva voce with equipments. So this is one thing that can be kept at any places. So one thing that what we need to understand is when we talk about the critical care management with regards to the airway, airway has two broad components. One is the strategy and other is the skill. So that's why I said you may be asked to demonstrate some placement of a airway gadget on a simulator or maybe a task trainer. So you should be well versed of using the basic aspects that you are aware of. Some newer equipments which are being added to our armamentarium, like high flow nasal cannulas, Thrive, which have come RMS in the COVID time also. These are the relatively newer tools which have found a very good role in the critical care area. And now even in our critical care setup, we have been using these equipments as a rescue to delay the intubation or do an early extubation and then keep them on these devices. So you should be aware of the various criterias that will define that which type of airway gadget you should choose. And this is an important aspect. And this will be across all type of examination. You may be given a clinical case scenario in a theory exam and then can be asked that how or what strategy will you follow for the airway management. So that's why you should be clear that when to use Proceed LMA, when to use HFNC, when to go for a tracheal intubation. So this is one aspect. Second aspect in the airway, which is again very important, is with regards to the type of difficult airway. Majority of time, we usually talk about anatomical difficult airway. Mouth opening is less, patient is obese, there is short neck, the neck movements are not sufficient, there could be mass in the head and neck area, there could be a thyroid swelling, there could be a mucositis inside the oral cavity, maybe the patient is post chemotherapy, febrile neutropenia with mucositis, there could be bleeding. So all those are part of the anatomical difficult airway wherein you need to have a strategy. When we talk about the ICU setup or a critical care unit setup, nowadays we are also talking about physiological difficult airway, and that is very important. And that is the any examiner who had a little thrust into the airway or having a little interest into the airway, they will take you directly to the physiological difficult airway. What is physiological difficult airway? You should be able to explain them that what is physiological airway, difficult airway, how will you assess this patient for physiological derangements, and what strategy will you take so that they do not decompensate. Let me show you an example. Say a sepsis patient who is going into ARDS type picture. He is being kept on CPAP, and now he is not tolerating CPAP, or even after CPAP the PF ratio is quite low and you decide to intubate these patients. Now herein you will start thinking, if you remove the CPAP, patient will desaturate. Patient may be on ionodrop. If you give some sedation, the BP will fall. Simultaneously, if you do anything, the catecholamine response is so high, they can have fluctuation in the blood pressure. If a patient is hypoxic, if you do a laryngoscopy with sympathetic stimulation, because of the mismatch between sympathetic and parasympathetic area, these patients can have bradycardia. So now these are the physiological issues when you start managing these difficult airways. That's why you should be a little cautious. And if you see the literature, you can be asked for the evidence also. And evidence says that in a critical care unit, it is the hemodynamic instability that is more of a concern during the airway management. So that's why on both the aspects, when you're managing about any patients for airway management, you should always talk about both the things, anatomical and physiological, and then make a strategy, then make a prognostication of the patient, and then choose your equipments and expertise accordingly. So this is one aspect. Second aspect is you should also be aware during the airway management if your plan fails. So that's why there are algorithms even which is by All India Difficult Airway Association, by Difficult Airway Society, where they talk about this stepwise approach. So whenever you speak in exam or you are doing some simulation or a clinical based scenario is given to you. Dr. Kadir, can you just mute yourself, please? Thank you. So you should be well versed in this situation, that you should be able to give a stepwise approach, that if the plan A fails, what you will do next? If plan B fails, what will you do next? So this plan approach should be mentioned into your theory paper, into your simulation practice, into your OSCE. So, and these plans are well described with the various algorithms. I will suggest you read at least one. From India, it is All India Difficult Airway Association Airway Management Guidelines, and it gives a stepwise approach. So you should be able to give them a stepwise approach for management, and same you should follow your, in case if your exam is going to happen in a center where they have simulation, they can ask you those situations. Third thing which is important is identifying the gadgets of airway management. So you should be able to identify at least 2 or 3 difficult airway armamentarium. You should be able to identify supraglottic airway devices, fiber optic bronchoscope, video endoscope, video laryngoscope, buoys, stillets, gum elastic buoys, tube exchangers. So you should be able to identify those equipments because they are part of your armamentarium. The other important aspect in the airway management is the surgical airway. Now, this is a very common issues in ICU setup, that you need a surgical airway because of many reasons. It could be that you are a failure in airway management and then you want to plan an emergency surgical airway, or it could be a patient is on a prolonged ventilation and you want to put up a tracheostomy tube for ventilation subsequently and lung hygiene. So you should be aware of all the techniques that are available to you. Whether we talk about the various modalities of percutaneous tracheostomies or surgical tracheostomies. So it should be very clear when to do PCTs, what options are available to PCTs, how it should be done, whether you need a fiber optic, whether you need ultrasonography for them, and what are the sets available or what are the techniques available for these type of airway management. Also, you should be able to remember that in case if you are stuck up somewhere, the emergency airway management is not tracheostomy, not PCT. It is emergency cricothyroidotomy. So you should be able to identify those things and try to teach them or try to explain the steps of emergency cricothyroidotomy. So this is different. So there are 2 different things I have just mentioned. One is the PCT and one is emergency cricothyroidotomy. So both the steps should be known to you well so that you can explain them and you can justify when to use them. So this is a skill-based procedure. So I will suggest each one of you that at least try to practice at least 5 to 10 in a mannequin, and then you can start at least assist with your seniors to have an observation of around 5 or so, and then you can start practicing under supervision another 5, and then probably usually 20 is the you can say the learning curve for these type of devices, and then you can start on so that you can do very safely and confidently in the exam. That is very, very important. Also, the other important aspect that you need to understand is how to extubate these patients. Majority of time in ICU, you start weaning off. Weaning is from a physiological lung point of view. But if a patient is having a difficult airway, the extubation or removing the tube also becomes an issue. So your extubation strategy should be important. Nowadays, across the world, people are concerned about the safe extubation practices, and then we have guidelines available for them so that you can do a safe extubation for these patients. So this is in a nutshell. You should discuss and talk about the airway, and the questions or the this management can come at any way. For example, say you are being discussed with a case of sepsis on ARDS, or a COPD patient, or a patient with the myasthenia gravis, or a patient with snake poisoning with the neurotoxic effect. So at any place, your airway management can come into situ, and if you have clarity about those things, you will sail through very smoothly, because the guidelines have made it very clear that what should be your step 1, step 2, step 3, or failure technique that you should be following in these methods. They are very, very clear, and you should be able to follow them. Another important aspect will be the assessment. And assessment, there are certain criteria and parameters we'll be discussing in the case discussion also tomorrow and subsequent days. You can go for any standard books that what are the parameters that predict the patients with anatomical difficult airway and patients with physiological difficult airway. And these will help you to make strategies that, yes, this is my strategy that needs to be followed for these type of patients. So this is how, in a nutshell, we can think about the airway management. If you have some specific points here, we can always discuss them. And you can ask them, you can unmute yourself and ask me, or you can chat in the chat box also, and I can answer it. Dr. Arindam, over to you.
Yes. Sorry, I was there.
No issues.
So, thank you on that part. And also, I hope they are also being appraised about the assessment, particularly the class you took on the FCRS on airway assessment, which is also a very integral part of our clinical examination. In fact, if the patient is not on ventilation on others, so there should be, every ICU patient should have a airway pre-assessment for airway management itself. So in case there is a need for urgent respiratory support, they can be optimally given, provided that.
So regarding the difficult airway extubation guidelines, we do have extubation guidelines from 2 societies. One is All India Difficult Airway Association, and second is from Difficult Airway Society. Both the guidelines, in principle, the science behind the things are same. You can read both of the guidelines and then make a strategy. Say, for example, a patient is having a thyroid mass, and then he is with some issues, say hypothyroidism or thyrotoxic coma or thyrotoxicosis, and then he is intubated for some time. Then you know that there will be tracheomalacia, and then the trachea will be collapsible. So the guidelines is a limb approach, where they will give you a scenario of all the aspects in a category way. Patients with surgical difficult airway, patient with having medical back history, or a patient like, for example, say patients with neurosurgical intervention, they come to you and you want to obtain the airway pressures, you want to obtain the hemodynamic response. So this guidelines will give you an idea. And the reference you asked, where you can just type extubation guidelines IDA, extubation guidelines DAS. So both the guidelines are free. And maybe I can share it with Dr. Kar also, and maybe if there is a group, he can put it, those guidelines, and they're free to use. I can share those things to you also. Regarding Dr. Bhumika Bihani, she wants to ask format of questions asked in long cases after more time.
So there are no format actually. Rakesh, do you think there could be format of questions being asked?
So I started my session from the same thing. Airway is such a thing that you can be trapped in any case. ARDS, COPD, organophosphorus poisoning, snake poisoning, extubation, surgical airway, medical airway. So I think there is nothing specific format. So what I say you, if you know that stepwise approach of your airway, first is assessment, second is stepwise airway management protocol if you are aware of, and then when and how to extubate. If you know those things, if somebody asks at any point of time any questions, you will be able to sail through. So I think we don't have a format, because airways, to begin with, in last 5 to 7 years, even all the critical care enthusiasts have started showing a lot of interest in airway management, because it was leading to a lot of morbidity and mortality. So I think that's the issue. With regards to please put the guidelines in group, we also wish to get, don't worry, tomorrow I'll be on my office system. So I'll put both the guidelines into the chat also. You can download from there.
Fair enough. I think you can put it in the chat box, or we have a group. I will include it in the group. Sure. You can put it there also. Sureshna, please put Dr. Rakesh Garg in the group itself, so that everyone can. And regarding his Bhumika, yes, please. Rakesh,
my WhatsApp has been hacked and blocked, so I do not know if it will work. But as soon as
put it in the Then kindly put it in the chat itself.
Yeah. I'll put in chat. You just put in the group. If my WhatsApp is working tomorrow, I'll put it there.
Okay. And regarding Bhumika's question, we would be discussing a lot in the debriefing session. So let us first finish, and once at the end of the third day, if you guys think that there should be sort of still something is remaining, something or other is remaining, then we can definitely discuss that. Did Amrita join? Okay. Anyone else is a? Otherwise, I would sort of tell that how the examination is going to happen. I think many of you have, it's little late, so many of you have left, right? So I would ask you so that you can tell your friends. And anyway, there would be a detailed instructions coming to you, or already it has reached the group itself. So what is the format of that exams? The mock exams is like that. We have, Sudeshna, how many people we have enrolled at the end? I think around 84 or 86 or something of that sort, if I'm not mistaken. So initially I thought that there should be 40 candidates, because in that 40 candidates, we can take the complete set of examinations. Then I saw that there are quite an overwhelming response, and there were almost 84 candidates have actually enrolled in. And I thought it should not be fair, because you all are friends. It should not be fair to give someone entire opportunity and deprive someone of the rest of the things, right? So we thought that at least let us split it up and let people have at least experience the 50% of it. So we thought that we will allow 80 people to take exams, but we'll have to split it up. So that means 80 people would be giving a 50% of the exam itself. So one part will give one long case and 3 table vivas, 3 components of table vivas, right? Sorry, 2 components of table vivas, and another part will give 1 short case and 2 parts of table viva. And in that process, but what would happen is that every one of you will go through the entire options of the long cases. So we will have 4 long cases, 4 short cases, 12 components of table vivas, and 35 questions of OSCEs presented in a PowerPoint. So we'll start with long case. Then we'll go after long cases are completed, 4 long cases completed over 2 hours time. We will do a debriefing of long case. Then we'll have 4 short cases of 15 minutes duration. Then again, we'll do debriefing. And then we will do a OSCE. OSCE would be displayed on a PowerPoint presented by Dr. Vivek Jain. 35 questions in 45 minutes. You have to write down the answers, and immediately after the OSCE being done, the answers would be revealed in a debriefing session. And you will self-correct yourself and give yourself the own marks, right? This is how it goes. So there are no marks, no pass, no fail, nothing. Self-assessment and assessment by the examiners given directly to you, as well as your friends are anyway watching your performance. So nothing to worry. Everyone would depose examination in front of the others. So I hope everyone would be in the same soup or the same condition. So nothing to be ashamed of in front of your friends. So first day, that means tomorrow, day 2, would be long case, short case, and objective structured computer-based evaluation of certain imagings and graphics. The day 3, that means second day of mock, that means Friday, again we'll start at 4, and we will have 12 different tables as given to you, including ACLS, ATLS, air weight, drugs, procedures, hemodynamics, ventilation graphics, then your log books, appraisal of thesis, appraisal of study. So everything on that. So every table will have 15 minutes of duration. And after that, we will do again a debriefing of the questions. And what would happen is that we will have, you guys will come, log in, come to a common meeting room, And then according to your candidate number, which would be given in the group itself, you will be allocated a meeting room, a separate meeting room. That means if I say that Sony Thomas, I can see. So Sony Thomas is candidate number 1, and she is allocated on meeting number group A. That means meeting breakout room number A. So that means Sony Thomas checks into the common room and then goes into the group A breakout meeting room. So he enters that meeting room and sits there. So entire 2 days, he would be in the candidate number 1 would be in the meeting breakout room A, along with 8 other people. So we have 80 people approximately. So 8 people in each meeting room, and each of you will get your turn to depose for examination. So once Sony is giving an examination, rest of the 7 people are looking into it or listening to it. So that's how you would be exposed to it. And in the second exam, someone else, maybe Manoj MS, he is candidate number 2. He is also allocated into the breakout room A. So he will be the second candidate who is deposing exams. Then Sony and other people, 7 other people, are watching the examination. So the examination will happen in the breakout rooms, one-on-one, and the rest of the 7 people will watch. But during the debriefing, you will again, all of you will come back to the common room, and the debriefing will be common, along with all the examiners and examinee. Is it clear and understood by you? I want a little bit of verification from you guys. Thank you, sir. Understood, sir. Yes, sir. So you guys are smart. I think I am the dinosaur only one. So, so this would be, and every breakout room would be monitored by our people. So they will guide if anything is there. And all the exams, this is a big exam, so it is conducted online with 84 people with 65 faculty. So it has to be absolutely time bound, and it has to be an A. So you have to no part of delay, no part of logging issue. So be sure about your connection, your backup connections, your timings and everything. So we cannot, so many people are involved, so we cannot wait for anyone. Regarding the cases, you will receive in the group all the vignettes or introductory vignettes of the long case and short case by 2 o'clock, right, tomorrow. So that's only a, as well as again 2 o'clock, day 3, you will receive the 5 different study paper, right? We will have 5 different study papers, and that would be, you have to read all the 5, and one of those would be asked. So 5 different study papers, and we will give you OSCEs are impromptu. So 2 o'clock you will receive the cases, the short cases and long cases, the first introductory vignettes, and then the subsequent vignettes and the flow would be asked in the live examination itself, right? So that's how it goes. And table vivas and all vivas are obviously impromptu. You don't need any preparation for that. Only other preparation would be about the study that has to be appraised. So that would be given on Friday, 2 p.m. in your WhatsApp group. So anyone who is not present in the WhatsApp group, please, you can write to text to me or Sudeshna and get yourself included into the WhatsApp group, because all the information would be flowing through the WhatsApp group itself. And at the end of debriefing, Friday night, if I am still alive, I'm very tired on that, we will discuss about it. Or maybe if things go in that way, and if there is a demand of it, we can meet some other day before your examination. But I think this would suffice. Let's go through it, how it goes. Some of the things we will create for you, particularly a format of clinical examination and summarizing the case. And and also maybe how to answer, how to present yourself and all others. Maybe whatever I have written down, I don't know whether you have taken notes. I have taken notes and summarized most of the things that I have learned, and I have tried to also make it formal for you guys to do that. And 5 hours now, sir. Truly appreciate. Yes, sorry. Thank you for your
Sir,
kind words. So
I have a query.
yes, Sudeshna.
Sir, do every candidate has to keep their, when they're giving the examination, do they have to keep their camera on?
Camera on should be sort of a mandate during the exams. That's, I think that is also what I would say, that is also a basic requirement in actual exams. I can say that that's a must and requirement. But for mock exams, I would say that is not a requirement, that is a courtesy, that you have to have your camera on, right? And you should be in a more formal way.
So I would request every candidate
Yeah, Sriram is saying
log
that,
into...
sir, the exam can be viewed by everyone. Yes, the people, 8 people within your group, that means your breakout meeting room, 8 people would be there. So if you are giving exam, Sriram, rest of the 7 can view that, not rest of the 80 people. Only 7 people within your group will be seeing your exams. And the group has been randomly allocated by Sudeshna. So we don't know who is your friend, who is your foe. So we have randomly allocated.
We would request everybody to join through laptop because
particular candidate will get 1 long or 1 short case and along with 2 table vivas. So minimum of 1 hour of exam time. Sriram, how can we access if you are not registered? You have to register. You see, the only thing we have made it complimentary, but at least you have to register with Sudeshna. And if you are, and candidates who are late and beyond 80th number can only observe. I'm sorry for that. You can only observe that part. That's why I always said that initially we were asking for only 40 candidates. Then we extended to 80. But beyond 80, if you are late, you can only observe. You cannot give the exams. But you are free to observe the entire exams. We will accommodate you in any one of the breakout rooms. Okay, so if there is nothing more, then I will take a leave and go home. We have still some work. Sudeshna, all the cases will reach you. And
yes,
we have to
that's
make
what
it in a PPT format. Huh?
Yes, that's what I'm worried about.
You don't have to worry, all are ready. We have readied it.
Oh, perfect. Perfect. So,
thesis and
anybody...
log for Savya, thesis and log. See the format. It's on the 3rd day. Tomorrow is long case, short case, and OSCE. OSCE is live, PPT based. You have to write down the answers. We'll keep you the questions on a PPT format. Rest long case, short case, 1-to-1 on a verbatim basis, and tables would be on day 3, that means on Friday, and one of the tables is thesis and logbook. So this is on day 3. Sriram, you can text me or Sudeshna. Sudeshna, can you type your number?
Yes, I will just do it.
Oh,
yes.
Sudeshna has given you the link to register. Okay.
I'm also giving you the number.
Thank you, Jairam. You can appreciate it was a huge effort. I have called up almost 100 people myself while working full time over here and all others. Then my colleague Vivek has done that, and all the cases me and Gunjan has to sort of build up and then verify it with a lot of a. Then I had to call up all the people to get them going to join here and come up with the questions, ask them, and also to encourage you guys to stay with us. So see you tomorrow by 2 p.m. You will receive the long case and short case scenarios. And and you just be honest with yourself. Do not open book and read about it, because if you cheat in the mock test, you would be cheating yourself, no one else. So you just read the cases in 2 hours time, mentally prepare yourself. Don't read from the books, don't open books, and prepare yourself for the. And also one good thing is that when one of your friends is giving exam and you are observing, I would say that you can mentally make up your answers too, and match those answers with the ideal answers when we would be debriefing, so that you can also assess yourself that how well you did in a imaginary exams itself. Okay, so that's it. Okay, so we'll meet tomorrow. Bye, and have a nice good night on that part. Bye.
Thank you, sir. Thank you.